Okay. Good evening, everybody, and welcome to one more session of the discussion of the grand test. So, over the next few minutes, we'll be discussing the answers for the grand test that you appeared yesterday. And this is in the final sprint of the NEET PG 2026. So, I'll be discussing medicine and allied questions. So, the first question here, 40-year-old recurrent peptic ulcer hypercalcemia has confirmed to have a MEN1 gene mutation. On physical examination, several flesh-colored papules you're seeing on the face and trunk. Which of the conditions is most frequently associated with these patients? So, you know the MEN syndrome. So, you have M1, MEN1, and MEN2 and 3. So, here, the most often tumor that is associated is an angiofibroma. So, the answer for this is B. And it's important that it's associated with parathyroid, pituitary, as well as pancreatic, and type 2 is associated with pheochromocytoma that you commonly see. 15-year-old hepatic dysfunction, KF ring positive. Laboratory evaluation shows low ceruloplasmin level and increased 24-hour copper. So, you know, the diagnosis is Wilson's disease. So, Wilson's disease is the diagnosis. So, which of the first line drug? So, is it zinc acetate? Is it D-penicillamine? Is it triantine? Is it tetrathiomorbidate? The first line drug is D-penicillamine. So, the answer is B. All the options are correct, but the first line drug is D-penicillamine. 45-year-old is brought to the emergency after a smoke inhalation during house fire. And this is the oximetry you can see there. It's showing a 98% and heart rate of 88. However, the patient is tachypneic and drowsy. Now, why is this discrepancy? Very, very important. Always remember, in carbon monoxide poisoning, the pulse oximeter overestimates the oxygen saturation, the carboxyhemoglobin that is there. And that is why the pulse oximeter always overestimates the saturation. If you take an ABG, you will find the PO2 being low. So that is very important to understand. In the ABG, the PO2 will be low. This discrepancy is very characteristic of carbon monoxide poisoning. So the answer here is A. 5-year-old cystic fibrosis, chronic productive cough, recurrent respiratory infections, poor growth. Laboratory shows a pancreatic exocrine deficiency. What is the best explanation that is given? So remember, cystic fibrosis, you have the CFTR mutation, and there is a defective chloride bicarbonate transport, and that's why the secretions get inspissated due to an impaired clearance, and the lung, the pancreas, meconium ileus can be there. So the answer for this is A. 14-year-old, short stature, premature graying, early onset of cataracts, severe atherosclerosis, diabetes, osteoporosis. So, you know, this is a progeria syndrome which you're seeing. And here you have a mutation of the RECQ helicase. This is very characteristic of Werner syndrome. So, Werner syndrome is one of the progeria syndromes where you have the RECQ helicase defect. 35-year-old tuberculous meningitis, you find that the CSF is lymphocyte predominant, glucose is low, protein is elevated, low chloride, pellicle formation, that is a cobweb formation is seen, and gram staining cultures are sent. Now, out of this, what is the very, very important feature? Please remember the cobweb formation, that's because of a very high protein that is very characteristic of TBM. We don't get it in any other condition. 68-year-old hypertension and diabetes, comes with dyspnea, edema, JVP is elevated, crepitations are there, edema is there, you find cardiomegaly and pulmonary congestion, EF is very low, NT-proBNP is positive. So this patient has congestive cardiac failure. Now, what's the mechanism for this symptoms the patient is happening? Please remember the cardiac output is decreased, and that results in neurohumoral activation, and that is the cause. So the answer is C. 27-year-old traumatic brain injury in the ICU. His spike, you find that the pressures are spiking at 735, bradycardia and hypertension. So this patient is having a Cushing's reflex you're seeing there. So raised ICT is happening. What's the first thing to start? Always start on osmotherapy. You can start on glycerol. You can start the patient on mannitol, hypertonic saline. You can start them on those. Later, you can start them on corticosteroid therapy or some other things, but main therapy is osmotherapy that we have to do. 27-year-old emergency, pain, abdomen, nausea, low-grade fever. This is the sign getting demonstrated there. You can see there. The left hypochondrium is pressed and the patient is having tenderness in the right. So this is the appendicitis Rossing sign that is classically seen. 61-year-old hoarseness of voice, difficulty in swallowing, unsteady gait, ipsilateral weakness of palate, pharynx, larynx, Horner syndrome, ataxia. Sensory shows loss of vibration and proprioception on the opposite side of the body. Which of the brainstem syndromes classically explains this feature? So remember, so there is one-sided 9th, 10th cranial nerve and Horner's, that is the sympathetic tract, as well as you have ataxia. So this is the lateral part of the medulla, but the crossed medial lemniscus is also getting involved. So this is very characteristic of the Sestan-Canis syndrome. Please remember in Wallenberg syndrome, the proprioception is preserved. It's the pain and temperature it is lost. So this is a crossed medial lemniscus getting involved. So this is the Sestan-Canis syndrome. Here you have a boy, we see a lot of neurofibromas. You can see the Lisch nodules here. So you know the diagnosis is neurofibromatosis. What's the treatment you have to offer? MEK inhibitors, that is the selumetinib has to be started early. 60-year-old anterior wall MI comes with a dizziness. You have a wide complex tachycardia. In a underlying setting of MI, it is always VT, and the answer is monomorphic VT that you see. There is AV dissociation. That is again a feature of VT. Gritty sensation and burning in the eyes. You see this test being performed. This is the classical Skirmer's test. And we do it for keratoconjunctivitis sicca, that is Sjogren syndrome. 69-year-old stage 5 CKD is scheduled for dialysis. Which of the following statements is incorrect? AV fistula has superior patency. Tunneled catheters have lower risk of infection. Radiocephalic fistula is the first choice. Infection is the most common complication of AV fistula. Infection is the most common complications of catheter. AV fistula, it's bleeding or hematoma or block being the complication. So the answer which is not correct is C. Patient comes with early morning stiffness, anti-CCP positive. So you know the diagnosis is rheumatoid arthritis, and the hallmark of rheumatoid arthritis is formation of pannus. So answer is B. Cartilage erosion is osteoarthritis, TOFI is in gout, and CPPD shows CPPD crystal. So the answer here is B. Graves' disease, progressive eye irritation, there is proptosis, enlargement of extraocular muscle. So you know this is Graves' ophthalmopathy. What is the mechanism? TNF-alpha related mechanism is what is proven for this. 7-year-old sore throat, malaise, tender anterior cervical lymph nodes. Pharyngitis is there. Purulent tonsillar exudates. Cough, coryza, conjunctivitis is not there. His sibling also had it. A throat swab sent for the detection of rapid antigen detection. Rapid detection test is done there. Which is the correct symptom that which among these is most accurate? A negative RAT-T rules out the disease. Viral infection should be strongly suspected despite of purulent. Incubation period is 7 to 10 days. No, incubation period is short. The throat culture is the gold standard, especially in high-risk patients. So the answer for this is B. Chronic smoker, shoulder pain, small muscle wasting, ptosis, and chest X-ray showing this shadow here with rib erosions. This is the classical Pancoast tumor. So superior sulcal tumor, answer is B. 40-year-old drowsiness, sodium is very low, and then the sodium is corrected. Within 24 hours, it's been corrected for more than 10 to 12 milliequivalents. So because of that, the patient has gone into altered sensorium. So you know this central pontine myelinolysis, that's the complication that you're doing, or what we call it as an osmotic demyelination syndrome. So the diagnostic test for that is an MRI brain. 1-day-old has not urinated. What do you do? So this could be normal. So just observe, continue breastfeeding and observe. Fever, dysuria of 2 days duration. Urine shows 8 to 10 pus cells. Which of the following cultures would be diagnostic? So please remember, diagnostic would be more than 10 to the power of 5 with a single organism. So clean catch urine. That's the answer C. 4-month-old, worsening cyanosis and poor feeding. Cyanosis is worse on crying and feeding. Exam shows heart rate of 130, saturation is low. There is ejection systolic murmur and a palpable RV impulse. You know this diagnosis is a tough. So when there is cyanosis, what do? You give knee chest position and oxygen. That's the mainstay of therapy, and then you can proceed for specific therapy, but immediately we do the knee chest position. Child has warm autoimmune hemolytic anemia and steroids have been given, no change. So you know the diagnosis is an immune hemolytic anemia. You will start them on immunosuppressive agent add-on with steroids. 32-year-old lady, G2P1, 22 weeks of gestation, ultrasound reveals enlarged head circumference with significant dilatation of the lateral and third ventricle. What is happening to this baby? So possibly the most common is an aqueductal stenosis resulting in dilated ventricles. 30-week gestation preterm develops intermittent pauses during sleep. Some episode shows absent airflow but persistent chest wall movement, while other shows absence both. There is no sepsis, there is no metabolic abnormalities. So what do you think this patient is having? So this is what we call it as a mixed apnea, both central as well as peripheral. Both features are there. That's what you get in this patient. Infant is found to have elevated LH, luteinizing hormone, 46XY chromosome pattern. There is short vagina ending with a pouch, which is incorrect. So you know that there is an LH surge here, 46XY. So absent internal female genitalia. Affected individual will have a female phenotype because X is there. Testicular malignancy may be there. The normal internal genitalia will not be there. So C, internal genitalia also are affected. 7-year-old has difficulty in running, frequent falls and proximal weakness. You can see the classical Gower's maneuver which you're seeing here, which is classical of Duchenne's dystrophy. So which of the following is true or false regarding this condition? So we are diagnosis Duchenne's muscular dystrophy. Symptoms in early, X-linked, cardiomyopathy is associated. It is less severe than Becker's. No, it is equally severe than Becker's. Becker's would come later. Sometimes this is more severe. So the answer is D. Pharmacological agents most potent in acid suppression. Please remember, especially in children, PPI is the drug of choice. 3-week-old cough, sore throat. Paroxysms of coughs are there. Counts are very much elevated. So, you know, it could be pertussis. The drug of choice for pertussis is azithromycin. So here, classical video, you have the Treacher-Collins syndrome, where the characteristic facies is there. The mutation involves the TCO51 gene. That's the characteristic feature that is very, very important. 25-year-old final exams feels a detachment from his body as if it's watching from outside. His surroundings is unreal. He knows these experiences are not real and correctly identify these two phenomena. So the first phenomena is depersonalization. Second is derealization. This can happen during extreme stress. It is not a pathological. So this is the answer for that. 25-year-old dental clinic, severe erosion of the lingual aspects of the front teeth, swelling of both cheeks, there is parotid enlargement, there is scars on the dorsum of the right hand. Very, very characteristic. This is your bulimia nervosa, eating lot and then putting the hand and vomiting. So what would be the characteristic feature? Elevation of salivary isomylase. This is the answer. So B is the answer for this condition. 40-year-old severe depression. I keep thinking about how worthless I am, how hopeless my future is. I don't try to stop these thoughts. That's the first case. 35-year-old with OCD says, I keep thinking that I will harm my family. I know it's senseless. I try to stop, but I cannot. So what is this? The woman is having classical rumination and the man is having obsessions. Child is having these scaly lesions. So what is this is the pityriasis rosacea that you're seeing there. Classical treatment is oral glycophalmin. KH mount, you will have to do it. 35-year-old, inflammatory papules and pustules in the central phase, no comedones. So what's the first step? You would start with topical antibiotics, metronidazole plus sun protection. What is this classical image? You have a lichen planus. You can see there isomorphic lesions along lines of trauma. These are seen in lichen planus. This can be seen with psoriasis. This can be seen with vitiligo. This can be seen with molluscum contagiosum. This phenomena is called as the Koebner's phenomena. 35-year-old progressive asymptomatic lesion, chest X-ray shows calcification with a tuberculosis is the most likely. So this is the lupus vulgaris you're seeing. Classically, you would do a PCR for tuberculosis in this patient. 23-year-old general anesthesia with halothane complains of hyperthermia, muscle rigidity, and acidosis. This is the classical malignant hyperthermia you're getting, and the drug of choice for that is dantrolene. You cannot use a peripheral reduction. You'll have to use the central ryanodine receptors. Dantrolene is the drug of choice. Patient with bacterial vaginosis treated with metronidazole, which should be strictly avoided. Please remember alcohol, because it produces with metronidazole, it produces your disulfiram-like reaction. 28-year-old generalized tonic lesions on phenytoin develops ataxia after a small increase. Plasma phenytoin just rises, just a small. So very characteristic, zero order kinetics, because it just rises up even with a small dose. Hypertensive male posted for hernia under spinal anesthesia. Shortly after injection, he developed hypotension and bradycardia. Despite normal respiratory effort, he begins to lose his coughing ability. So what is the best mechanism that is explaining, and how do you manage? So this is because of spinal anesthesia, sympathetic blockade causing venous pooling. Drug of choice is mephentermine that you see. 62-year-old Colles fracture, low backache, mineral density is 2.5. Which of these statements regarding the management is incorrect? Oral vitamin D3 along with calcium, right? Calcium requirement is 1000 to 200 milligrams per day. Bisphonols are not given for more than a year, and teriparatide should be started before supplementing with bisphosphonate. The answer that is wrong is calcium 1200 milligram per day is wrong. When do you use COMT inhibitors, the catecholamine omethylase transferase inhibitors in a Parkinson's? You use it classically whenever there is an advanced disease with motor fluctuation after starting carbidopa-levodopa combination. That is where you start it. Child with ALL, high dose methotrexate, mucositis and pancytopenia. So what's the mechanism here? It is because of DHFR inhibition. You should start folinic acid. Thymidylate sectase is in rheumatoid arthritis. Woman with UTI is prescribed an antibiotic which can cause tendon ruptures and arthroplasty. So you're dealing with the fluoroquinolone, that is the cause, and it acts by the DNA gyrase inhibition. Retroviral, Maraviroc is started. So Maraviroc is CCR5 inhibitor. Patient treated with aminoglycosides. The physician notes that bacterial inhibition persists after several concentration of the blood is reached below the minimum. So this is what we call it as aminoglycoside-induced post-antibiotic effect. Patient is on salbutamol and ipratropium. Symptoms still persist. So this is an asthmatic patient. Please remember the drug of choice is inhaled corticosteroids. So the answer is LABA plus ICS has to be the mainstay therapy. Toxic multinodular goiter, wanted surgery. Considering the nature of iodine, how do you give radioactive iodine? What is the best method? So please remember, radioactive iodine emits beta particles and the therapeutic dose is 3 to 6 millicurie. Patient has GRD on omeprazole, but symptoms are not relieved. The faster acid suppression, which is the best drug that is there, the fastest among them is rabiprazole. True regarding malaria surveillance. Is it active detection occurring in tertiary, passive occurring fortnightly visits? Microscopy is avoided due to low specificity. ASHA uses RDT. So please remember, ASHA are using RDT. That's the correct answer. Which of the following best explains the India's NLEM difference from the WHO list of essential medicine? Please remember, India's must include medications are the National Health Program. So that is the most important one compared to WHO. Which of these are not correct with respect to National Program for Prevention of Cancer, Diabetes, CBD and Stroke? The program is implemented in 40,000 sub-centers. That itself is wrong. It's only 20,000 sub-centers that have been used. It's going to use all the rest, but the first option is wrong. Burkitt's lymphoma in Africa and the leading role of Epstein-Barr virus. What is an example for? So you're observing association. So this is a descriptive epidemiological study. Kala azar is detected, vector shows resistance, no resistance, and breeds near cattle shed, which is the most effective. So sandfly, you will put DDT to the crevices and cracks. Which of the following correctly describes the referral protocol for Suraksha clinics? All STIs are referred to tertiary care? No. No referral is required for treatment failure. It has to be. HIV testing is mandatory for all. Without consent, no consent is needed. Follow-up is done. So this is a very important. If lower abdominal pain is there, they are followed up on day 3, 7, 14, and then referred if needed. Now, this is a pyramid population that is given. So what is the important thing that you're seeing? Is it a stationary period? It's a low mortality and constant fertility rate. That's right. Population growth is slow, reproductive and post-reproductive greater than the pre-reproductive. That's right. It is not a stationary, it is a dynamic. So answer is A is wrong. Black eschar in the cavity that is present, what is the best way to diagnose? So obviously it could be a fungus. So you will do a QH mount and a fungal culture. So that's the answer for this. 2.6 baby, 26-year-old mother, which is the best newborn eye care immediately? What you do is 1% silver nitrate, that is for prevention of ophthalmia neonatal. Copper T is contraindicated during menstruation, after a Bacron condom, in gestational trophoblastic, immediately after delivery. It is contraindicated in gestational trophoblastic disease. Now, this is the BCG vaccine, which is the which of the following statements is correct in these patients? So, is it a heat killed? It's a live attenuated vaccine that you're seeing there. It is not a heat killed vaccine. It offers 90%. No, it does not offer 90%. It should be reconstituted with sterile and used immediately. Yes, within 3 hours, we want to use it. So this is the correct option that we have. Cyclops acts as an intermediate host for dracunculosis. That is what you have to remember. Consistency of association implies that same result is occurring in different studies and different. That is the consistency. Pregnant women receive free antenatal checkups, medications, delivery services, including LSCS. What is the full form of JSSK? Janani Sishu Suraksha Karyakram. That is the answer. Clinician reviews case control study, smokers, odds ratio of 8:1. What's the correct answer? So it's a simple odds ratio is just saying that the risk is higher. Smokers have a 8.1 times higher risk. So answer is D. This symbol, very characteristic, is of biohazard. 20-bed hostel room with poor ventilation begins stuffy to occupants. At what indoor level of carbon dioxide does it typically occur? Please remember, 0.02% is where this stuffiness occurs. Female with the pregnancy of 22 weeks after sexual assault is seeking for MTP, which is correct. Now, MTP, one doctor's opinion is required for MTP in 20 to 24. No. MTP can be performed between 20 to 20 if it is life-saving. MTP can be performed in this case. MTP can be performed irregular. So remember, this is a select case. There is a sexual assault more than 24 weeks. You can do it up to 24 weeks in this case. Match the following. National Crisis Management is National Disaster Management, State Disaster Management, Ministry of Home Affairs. So remember, Ministry of Home Affairs is the overall coordination. So 4 goes to A. National Crisis Management is primarily looking into the disaster part that is there. So 1 goes to B. National Disaster Management is primarily concerned with the direct, and state direct management is the crucial level. So the answer here is D. 35-year-old patient, malaise, fatigue, 2 months, HbSAg positive and IgM core is positive. This is acute hepatitis B. So this is a classical of acute hepatitis B diagnosis that you get. So these are some of the questions which have been discussed. So we have discussed the options and what is the correct solution for that. Hope this session was clear. Thank you.
Hello, dear students. How are you? How was your grand test too? I hope it was a great success. I'm sure OBG was a cakewalk, isn't it? So you knew the concept, you could answer this all very clearly, isn't it? Yes, I hope you have done your exams well. Yeah, it was good. Yeah, very good. And one more thing I want to tell you is don't be overconfident or don't be underconfident. Okay, whatever you're doing is correct. You're just appropriate. You should not be underconfident or overconfident. However, your exam results were good, bad. Your preparation on the same way. Okay, so you should not have any sort of disturbance in your exams. Okay, I'm sure the OBG concepts you are very clear and you have answered it really good. Okay, so let us see how we can do with these questions right now. Let us discuss quickly so that we don't waste your much time. And remember, this is jam. Okay, so to start with the first question, yeah, this is the first question. A 19-year-old primary gravida at 18 weeks gestation requires termination. Okay, so at 18 weeks, do we allow for termination? Yes, up till 20 weeks for failure of contraception, we can allow for MTP, no problem. Okay, and with consent of how many doctors? Yes, up to 20 weeks, it is one doctor. 20 to 24 weeks, it is two doctor. But remember, the cause bit for 20 to 24 weeks should be very different. If it is just failure of contraception, it is only until 20 weeks. Okay, so let us see what is the question. Which regimen provides the shortest duration of abortion interval? So now here they have asked you about the medication. What is the best drug to give? Misoprostol alone. Okay, for abortion per se, alone misoprostol or any single drug is never used. Okay, it is always in combinations. Misoprostol alone is vaginally is a drug, but it is not alone. Alone is a wrong word. And high dose oxytocin infusion. Remember, oxytocin infusion is used in augmentation of labor. Okay, let us take a 24 weeks is there. We have given a MIFI meso and now we are augmenting labor. So that time when we have a good control, what will happen with meso? You will give off orally, then it can cause hyperstimulation also, isn't it? But in augmentation, we want a controlled stimulus. That time we use oxytocin as it causes control. If there is hypercontraction, we can reduce the dose. If there is less contraction, we can increase the dosage, isn't it? That is the basic reason. Okay, so you understand? Oxytocin alone is used only in case of induction, augmentation of labor than directly for induction. And this is used with Bishop score how much? If Bishop score is more than 6, that time we use this. Otherwise, we do not use oxytocin directly. So again, this is wrong answer. Mifepristone followed by misoprostol. Yes, this is the drug of choice, isn't it? We have read multiple times, and so many times also they have told us that mifepristone and misoprostol, this is the protocol drugs that we give. So when do we give mifepristone and when do we start misoprostol? Once the patient approaches to us, first we'll give mifepristone. After 36 to 48 hours, okay, after 2 days, ideally we start with that of the misoprostol dosage. Okay, minimum of 24 hours and maximum of 48 hours we have to wait after mifi to start our misoprostol. Then dinoprostone gel anolin again is used where? Yes, it is used in case with induction of labor. When Bishop's is less than 6, we use dinoprostone gel. Okay, alone these drugs would not act better. Mifi and miso is the drug of choice. Okay. Next question. A 26-year-old primary gravida undergoes vacuum-assisted vaginal delivery for a prolonged second stage of labor despite correct cup placement and adequate traction. Where is the correct cup placement? Yes, this can be again your question. Correct cup placement is at flexion point, isn't it? Flexion point, which is 6 centimeters behind the anterior fontanelle or 3 centimeters ahead of the posterior fontanelle. That should be the center point of that of the, yes, the cup. That makes a good flexion maintenance. Okay, and anterior fontanelle is not closed in the infant, isn't it, or newborn? So that is why we do not want it to be close to here also. So maintain good flexion. It helps in maintaining good flexion and give a good traction. So both of them they have done, they are saying, and the fetal it is not delivered. Okay, so what is after what duration of unsuccessful vacuum extraction should the procedure be generally abandoned? When do you say, okay, vacuum is failed, now I'll go for cesarean? When do you say that? Yes, how many pop-ups? At least for 3 pop-ups we can wait. If there is 3 pop-ups without any descent, okay, or 6 pop-ups with good descent, okay, it was at +1 you have put, then +2, +3 it has come, then you can wait for 6 pop-ups. If there is no descent at all, then it is 3 pop-ups. You should stop the procedure. Understand? So as per the RCOG, it is 6 pop-ups with the descent. No pop-ups, it is 3. Okay. So it should happen within how much? 15-20 minutes maximum. So let us see the option. 4 pulls without delivery. Wrong. 4 pulls without delivery. 4 is again or direct wrong answer. So 3 is the one. So C and D's are confusion. Within 15 to 20 minutes or half an hour. Can we wait half an hour in second stage, that in late second stage? No, isn't it? We apply only in the later part when the maternal exhaustion of fetal disease, some indication is there. So we cannot wait half an hour. Maximum is 15-20 minutes. Okay. So the correct answer here would be C. Next question. Primary gravida has poor progress in the first stage of labor due to inadequate uterine contractions. Okay, so the contractions are not adequate, so it is poor progression. Which of the following is most common power related cause of prolonged first stage of labor? So they have only given you the answer. Inadequate uterine contractions, isn't it? That is the most common cause also for prolonged first stage. So what is it called? Is it constriction ring? It is one of the rarest complications. When there is obstruction, severe obstruction down and the uterus is continuously pushing, that time the constriction ring happens, not otherwise. So constriction ring is very rare. Uterine inertia, yes, this inadequate uterine contraction is called uterine inertia. Maybe because of overexhaustion, dehydration, inadequate nutrients. So uterine inertia is very common. In an Indian scenario, most commonly it is because of dehydration. Okay, patient is not given food, milk, water, nothing they'll give. They'll be NPO and waiting. They'll be so exhausted. So dehydration itself will cause uterine inertia. Okay, so that is the most common reason for uterine inertia. So uterine inertia is one of the most important power related causes for prolonged second stage of labor. Cervical dystocia also is common but not as common as uterine dystocia. Sorry, uterine inertia. And epidural analgesia. Epidural analgesia, remember, not much effect is seen on first stage of labor, but it is mostly seen in second stage. Prolonged second stage, instrumentation in second stage is most commonly seen with post epidural analgesia. That's all. Okay, it is not related to first stage of labor. Okay, you understood? Yes. Next question. A 24-year-old pregnant woman presents with mild lymphadenopathy. Okay, so there is mild lymphadenopathy. She reports frequent contact with the cats and consumption of undercooked meat. So your diagnosis should come off here. Undercooked meat and also lymphadenopathy. What is it? Yes, it is toxoplasmosis. We don't even have to see the option if this is the question, isn't it? So toxoplasmosis is the diagnosis here. Serology suggests protozoal infection commonly associated with congenital anomalies in the fetus. Okay, so the torch. So it is one of the torch which will cause fetal infections, isn't it? And it is a protozoal infection. Again, toxoplasmosis. Which of the following is used in the treat this condition? So they've not asked you the diagnosis here. So now you have to know what is the diagnosis and you should know what is its treatment. So now you know toxoplasmosis is the diagnosis and its treatment is what? Yes. Yes, it is spiramycin, isn't it? So this is the treatment of choice for toxoplasmosis. Very good. Next question. A 28-year-old primary gravida undergoes elective cesarean delivery. The obstetrician chooses the most commonly used transverse abdominal incision between the superior cos because of its superior cosmetic outcome. Okay, so which is the incision most commonly used? Yes, it is fan and steel incision. So you should know different incisions also. In this figure we have given you, I think I'm blocking the figure. So you can see here. So this incision, this is a midline incision and this incision is the curvy linear incision and this is the transverse incision and this is what we give fan and steel incision. Where we give fan and steel incision? It is 2 centimeters above the pubic symphysis. Okay, so if we can palpate the upper border of pubic symphysis, 2 centimeters above that, a curvy linear incision, the low one here. Okay, this incision is called as fan and steel incision. The second or the next one more most commonest incision is Doyle coin incision. Which is Doyle coin incision? If you can palpate anterior superior iliac spine here, 3 centimeters below that. Okay, so this is 2 centimeters above the pubic symphysis, that is 3 centimeters below the anterior superior iliac spine. Okay, it's this one. So 3 centimeters below a transverse incision is given. Okay, that is Doyle coin. Both are equally efficient, both can be used, no problem at all. So there is some debate between which is most commonly used. In Western countries, most common they are saying is a Doyle coin, but in India we still believe it as fan and steel incision. Okay, so let us see what is the question. Which of the following statement is incorrect regarding the incisions? Okay, if what we give is fan and steel. So in fan and steel, let us see. It follows the Langer lines of skin tension. Yes, that is why it scars very smooth and it is most of the cases invisible also if you have done good suturing. Okay, so it follows the Langer lines. Langer lines are the skin markings along which the skin growth or the skin cells follow. So if along with that there will be less scarring. Okay, so this is the correct answer. What I have asked is incorrect. And it is associated with lower incidence of post-operative pain. Yes, this is one more reason. Here we do not cut the muscles, we just separate them, isn't it? So that is the reason here we have less post-operative pain. Then, and it is associated with lower incidence of incisional hernia. Yes, always midline vertical incisions. Okay, these vertical incisions have more chance of herniation compared to a transverse incision. Okay, and it provides excellent access to the upper abdomen and preferred when extensive operative exposures are required. So it is so low down, just 2 centimeters above pubic symphysis. How can you see spleen or liver from here, isn't it? Upper abdomen is not at all well visualized with this incision. Okay, so this is wrong. Upper abdomen, for example, if there is a huge ovarian mass, we don't give fan and steel incision and open the surgery. We give midline vertical incisions. Why? We know extent is too high. With this, we will not be able to reach the upper border of the cyst. So it is very easily understood, isn't it? So that is the reason we don't use fan and steel incision when we have thoughts. Okay, this can be a complicated case where extensive surgery may be required. That time we always give a midline incision. So this is good with midline incision and not with that of the fan and steel incision. Okay. Next question. A woman conceived through in vitro fertilization underwent embryo transfer on 20th February. According to the standard obstetric dating, her expected delivery date should be calculated by. Yes. So how do we calculate? usually we calculate by adding 9 months plus 7 days, isn't it? So this is when we are using LMP. So this is how many days? This is equal to 280 days. This is the normal pregnancy duration we are expecting. For 40 weeks is nothing but 280 days. But remember, from LMP to ovulation or embryo transfer, embryo happening, we have 14 days prior, isn't it? So this 14 days will not be there for an embryo transfer patient. So if this is the embryo transfer date, that means the first 14 days were not there. So in this we have to subtract the 14 days, isn't it? So 280 minus 14 days would be 266. So by adding 266 days to that of 20th February, we will get the expected date of delivery. Now I have given you adding 266 days. In exam they may give you dates. By adding dates they can tell you when is the expected date of delivery. So you should be able to add this 260 days or 9 months minus 7 days, and then you will get the delivery expected delivery date. Okay, so this is how you will do. Okay, 280 days we are adding from LMP. Since the first 14 days is not there in the embryo transfer, now here we will add only minusing that 14 days, that is the 266 days. Okay, next question. This is the most easiest question in this paper, I feel. A 24-year-old woman presents with oligomenorrhea and hirsutism. So signs of hypertestosterone. Hirsutism is there and oligomenorrhea. Testosterone is raised. A short laparoscopic video of the ovaries shown below. What is the most likely diagnosis? In this video, it is very clearly seen these polycystic ovaries, and they are doing cauterization of this polycyst. You can see the cautery comes, molar polar cautery, and then it will cauterize and it will go back. So you can see the 4 mm, 4 thick, 4 cauteries and 4 for 4 seconds, the rule of 4. Okay, so you can see there they are cauterizing the cysts. So it is a case of polycystic ovaries. Now the new name for the polycystic is ovaries are what? The diagnosis for this is definitely a polycystic ovary. So what is your diagnosis they have given? So polycystic ovary is not the new diagnosis. What is it? It is polyendocrine metabolic ovarian syndrome. Yes, very good. So yes, so many of you have given the correct answer. I think Sai Teja has given me the answer for the previous question and also the first this question. Yes, correct. This is very clear, isn't it? So remember the rule of 4 for cautery. Okay, 4 places we cauterize, and for 4 seconds and 4 mm depth is what we answer. Yes, polyendocrine metabolic ovarian syndrome. So this is just a name change. The concept is still the same. Okay, there is no much change in the concept, but I'm sure there will be a question definitely on this because there is a new name change on this. Okay. Next question. A 32 weeks primary gravida with severe preeclampsia is referred for a fetal surveillance. The umbilical artery Doppler is shown below. Which Doppler abnormality is demonstrated? Okay, so this is the Doppler they have given. Maybe in your exam they'll give you a video also. So it will go like this, and then in diastole there is a flow, and again go up, again in diastole there is a flow. This is a baseline. Okay, so in diastole also there is a flow, in systole also there is a flow. This is normal what should happen. But here you can see in diastole there is reduced flow, isn't it? The quantity of flow in the diastole period is less. So it always starts, the Doppler changes will start as reduced diastolic flow followed by absent diastolic flow, and then there will be reversal of diastolic flow. This is how the changes will happen, isn't it? So I'll clear this picture 1 second and I'll show you. So this is the figure. Then in systole there is a flow, in diastole there is a flow, systole there is a flow, diastole there is a flow. This is normal. Okay, then let us see what is abnormal. So it will start with systole there is a flow, diastole there is reduced flow. Okay, you can get these images. Then what will happen? Then it will be systole there is a flow, in diastole there is no flow at all. Systole there is a flow, diastole no flow at all. Then finally what will happen? In systole there is a flow, and in diastole there is reversal of flow. Systole and diastole there is a reversal of flow. Okay, this becomes end stage. Okay, so in absent and reversal we almost have only 24 to 48 hours for fetal surveillance in triuterine. So within that period we have to deliver the baby. Okay, so this is the basic concept. Yes, so very good, Riza, I think so. So and this is a reduced diastolic flow. I'm sure they'll give you videos of this time, because there is so much update in the exam pattern, isn't it? So this video, you see there is a flow in the systole, if it is reduced or absent or reversal, and you will take the correct answer. Okay, next question. A woman present 6 months after undergoing dilatation and curettation for a molar pregnancy. There is a particular reason why we have included a molar pregnancy, because molar pregnancy got updated just in the month of July, just before your exam. I don't know whether the question will come or no, but you should be updated, isn't it? So just before exam, this update has come, so I've included this question. 6 months after undergoing dilatation and curettage for molar pregnancy. Okay, so we know the classification high risk strategy. I've given you in the next image so that you can take an image and keep. Okay, so it is 6 months, less than 4 months, 0 points. 4 to 6 months, it is 1, scoring 1. So here it is 1 scoring. And diagnosis of molar pregnancy, score is 0. But if previously it was abortion, score is 1. Full term delivery, score is 2, isn't it? Like that. Now complaints of persistent abdominal pain and distension, this is a complaint. This doesn't have any scoring. Her serum beta Hg levels remain elevated. Again, post delivery it's elevated is a significant sign, but it doesn't include in the scoring system. Chest x-ray shows multiple cannonball lesions. Is chest or lung metastasis have a score? No, this lung metastasis again scored 0. And what is the most appropriate management? In the amount of high risk for categories that they have mentioned, only one scoring we have got, isn't it? Molar pregnancy scored 0, cannonballs in the lung is scored 0, 6 months is scored 1. So it is only one. The risk factor is low risk. So less than 7 becomes low risk, isn't it? So it is a low risk category. So in low risk, which chemotherapeutic drug you want to give? Do you want to give multi-drug regimen, single drug regimen? Yes. What is it? Hysterectomy. Why? Okay, this is again correct. It is methotrexate. It is only one scoring is there. Okay, so a patient with what the patient have not even mentioned age of the patient. What if it was just a 24-year-old patient? Do you still want to do a random guy? Yes. Do you want to do still a hysterectomy? No, isn't it? So in no case we directly go for hysterectomy for molar pregnancy. Remember, molar pregnancy is the only drug, malignancy which is 100% curable. Okay, it is 100% therapeutic. There is no doubt that it cannot be cured. Okay, it is 100% timely when you intervene, 100% curable, and this was the first disease where chemotherapy was introduced and first malignancy which had a medical management and curing. Okay, so you should remember this fact. So we have medical management. When the score is less than 7, we go for a single dose regimen. When it is high risk, score is more than or equal to 7, then we'll go for a macro regimen or multi-drug regimen. Okay, so here since the score is only 1, we'll go for single dose regimen. Correct answer is D. And I was telling you, I've included this for particular reason. Remember, this is the old classification. Okay, see, this one was what I was talking about. If the patient's age is less than 40, score 0. And if it was previous molar pregnancy, it is score 0. Interval between the treatment and present malignancy, if it is less than 6 months, 4 months, again this one. Our patient was 6 months, so she'll come at a score 1. And pre-treatment beta HCG they have not given. They have only told post-treatment also beta HCG is elevated. That's all. These are the values. Largest tumor 3 centimeter, 3 to 5 and more than 5, you can remember. And sites of metastasis. Remember, lung and pelvic metastasis is score 0. Okay, only spleen and kidney is 1, GI tract is 2, and the brain metastasis is 4. And number of metastasis, if it is 1 to 4 metastasis, it is just 1 score. It is 5 to 8 metastasis, again it is more, and more than 8 metastasis is score 4. And this last one, the prior chemotherapy one, okay, this is no more there in 2026 update. Okay, so this you should know that this part has been removed. Okay, the 2026, the high risk factor, this part has been removed. If ever in your question they give a previous history of single dose or multi dose regimen, this is not included in your prior in your treatment risk factor assessment. Okay, so you should don't score in your present exam. This is removed in 2026 update. Okay, you should know this. Okay, Riz has a doubt. For stage 2 and 3, we calculate score. Stage 1 methotrix says stage 4 MACO. No, it is based on the risk factors. We'll decide whether we have to give single dose or whether we have to give a multi-dose regimen. You have to remember, even if it is stage 1, she is having other problems. Okay, so she's more than 40 years and she's having previous, it was after a term baby. If all the scores come up to more than 7, then she's high risk factor. Okay, so whenever there is a high risk factor, it is better we always give a multi-drug regimen. Okay. So coming to the staging, previously they told only uterus. Now the staging says uterus with cervix. Okay, uterus with cervix and that is stage 1. Yeah, confined to uterus, cervix. And stage 2, spread to the uterus but not and the other genital organs like vagina. Now the increment is broad ligament. Okay, broad ligament is included in stage 2. And stage 3, okay, it is metastasis to lungs with below diaphragm. Okay, diaphragm and below lymph node metastasis. If they have given you below diaphragm lymph node metastasis, then she is under stage 3. If they have given you above diaphragm lymph node metastasis, then it is stage 4. Other than that, she can have multi other metastasis also, like brain, liver, GI metastasis, and it is above diaphragm. If she is having a lymph node metastasis, it is stage 4. This is the recent update. Okay, lymph node involvement below diaphragm would be stage 3, lymph node involvement above diaphragm would be stage 4, and broad ligament involvement is stage 2. Uterus and cervix, anyways, it was understood, but still cervix involvement is stage 1. Okay, this is the recent update. Yes, this is the recent updated guidelines 2026. Okay, for the FIGO 2026 update. They have removed the prior chemotherapy one and they have added these things for the staging. And remember, previously we had only low risk and high risk category. Less than 7 was low risk. 7 and more than 7 were high risk. Now they are saying more than 13 is said to be as very high risk. Okay, so this is the one more update. So here we had told you more than 4 is high risk, 6 and below is low risk, isn't it? And now they've given you more than 13 is called as very high risk. So this is the recent update. So this updates we wanted to tell you, that is why we have given you this question. I hope you understood the update and you'll be able to answer in your exam. This update just happened in July 2026. Okay, that is the reason we could not add in the app, so we are telling it to you here. Yes, correct. Next question, is breastfeeding present, a breastfeeding women presents with acute lactational mastitis. Okay, so she is having mastitis infection post lactation. Most common is post day 4 and above, they'll have this mastitis. Okay, improper feeding, breast milk accumulation. So if they have asked you day 4 and above, it is very common to have lactational problems. And then culture is pending. Which of the following is most appropriate initial antibiotic? So for that, you should know what is the most common organism. Staphylococcus aureus is considered to be as the most common organism for mastitis, especially lactational. In this Staphylococcus aureus, methicillin resistant, okay, is very common. So methicillin sensitive drugs, okay. So Staphylococcus aureus sensitive is what we think is the infection. For this, dicloxacillin is the drug of choice. Okay, here it acts penicillinase resistant. Okay, so this is a penicillinase resistant. So if the bacteria even produces penicillinase, this antibiotic would not get lysed. So that is the reason we choose dicloxacillin. Okay, yes, correct answer. Very good. You people are well prepared. Next question. Okay, identify the device shown below. So this might be a bouncer. Yes, tell me what is the answer. Yes, raise and nucleus. Weird nucleus. I don't know why you guys keep so weird names also. Yeah, very good. Tell me the answers. What is the device shown? Laminaria tens, misoprostol vaginal insert, Lippes loop. I'm sure nobody will choose Lippes loop. I just told it and the answer came as Lippes loop. Lippes loop is a copper T, isn't it? In our class, I showed you the image of Lippes loop also. It was like this image with the stick thread. I showed you the image also. No, it is not, sir. Yes, yes, I got one correct answer. Okay. No, it's not Lippes loop. Lippes loop will be like this. Okay, white color like this and a thread. This is how you can see the quick revision, the live classes. In that class itself, I showed you the Lippi's loop. Yes, weird nucleus. You are really correct. Your correct answer is correct, definitely. But others. Okay, this bouncer I can still understand. These are the cervidal vaginal inserts. Okay, remember laminaria tents. These were used previously. In historically, it was used. How they will be like small tents. Chinese medication. These were okay. Small like this sticks they were. Okay, these sticks were tied together and inserted inside the cervix. So it will absorb the cervical fluid and swollen up, and then it will cause mechanical dilatation of the cervix. Okay, so they are mechanical dilators of the cervix. They were like sticks, small sticks, like a toothpick, a little thicker than that. Okay, toothpick like an image. So these 3-4 sticks they used to tie up and they used to insert, so that it will absorb the fluid, it will dilate, distend, and there will be mechanical dilatation of the cervix. So this is not a laminaria tent either. Then misoprostol vaginal insert. So you have seen definitely vaginal insert will be like a stick, small medication, like a what you say, a Dulcolac suppository. It will be like that. Okay, so it is not the suppository either. Again, I showed you Lippi's loop. So Lippi's loop is what? It is a for contraception we use. It will be a stiff material. It will be like metal. It is not a metal but a plastic with stiff material, and it will be like a loop, and then it will have a thread down. Okay, that is Lippi's loop. And cervidal vaginal inserts. Yes, you know Cerviprime gel, isn't it? That is your prostaglandin E2, which we use for induction of labor when the Bishop score is less than 6. Okay, so when the Bishop score is less than 6. So why I'm telling all these points are any of them can be your questions. So what is this misoprostol? Where do you use? Where induction of labor? Where do we get for whom when the Bishop score is less than 6? We use this. So all are your questions. That is why I'm telling all these things. So these are the cervidal vaginal inserts. Remember, the Cerviprime gel is intracervical. Okay, when it is intracervical, dose is 0.5 mg, whereas this is vaginal insert, this is 10 mg dosage. Okay, remember, this also may be your question. So this 10 mg dosage is cervidal, which is a vaginal insert. So this will be placed in the vagina. Slowly it will get released. Whereas Cerviprime gel, it is 0.5 mg. That is intracervical we will put. Okay, so this is used for induction of labor. Very good, weird nucleus. You gave the correct answer. It is a cervidil, it is a prostaglandin E2. This is used in induction of labor when the Bishop's is less than 6. Next question. This is a repeat question from your previous exam. A 28-year-old primary gravida presents for a routine antenatal visits in her second trimester. Okay, sorry. A 28-year-old pregnant woman presents for a routine antenatal visit in her second trimester. 4 years ago, she delivered a healthy full-term twins. What is the current obstetric score? Yes, there should be no problem in answering this. What is the answer? Fast, let me know. Mm-hmm. Yes, prostaglandin is E2 is a dinoproston. It is the prostaglandin E2 which is there in the Cerviprime gel. Yes, correct. Yeah, just confused. No, prostaglandin E2 is Cerviprime. Prostaglandin Cerviprime or Cervadil both are same. Prostaglandin E2 is nothing but dinoproston. The company or the brand name is Cerviprime Cervadil we use. Okay, prostaglandin E2 is dinoproston. This is only there inside this. Okay. There is no confusion. E1 is misoprostol, E2 is dinoproston. Your Cerviprime and Cervadil are the same. Dinoproston, 10 mg is vaginal inserts, 0.5 mg is your cervical, intracervical. Okay, you're correct. Saiteja, by mistake you typed or you typed it as the answer? Yes, Saiteja, tell me, you typed it by mistake or you typed it purposefully? That is what you thought? Yes, Dhanush, yes, the image that is shown is the cervidil. That is vaginal inserts. It is a small tube like where slowly the drug will be released. It is 10 mg dosage since it is vaginal. Since V prime is intracervical, the dosage is 0.5 mg. Okay, fine. Saitej is not answering. He's yeah, D. Okay, he's was little confused, I think. Okay. Okay, now remember, whenever they tell you a pregnancy it will count from whatever is the outcome, be it ectopic pregnancy, abortion, or chemical pregnancy, or whatever it is. She's been confirmed pregnancy, she will account in her gravida. Okay, so any pregnancy will be counted, including the present pregnancy. Okay, now she was pregnant 4 years ago, and now she is pregnant at second trimester. So she is gravida 2. Okay, now coming to para, where you're all getting confused. Para is where there is total number, don't think it as pregnancies, it is total number of deliveries. Okay, that has crossed period of viability. So she has crossed period of viability and delivered how many? Parity means delivery, isn't it? My mother is Paris, she has delivered 2 kids. My mother is having 3 kids, she's a Paris lady, isn't it? Parity is nothing but deliveries. So how many deliveries she had? For example, in this, how many times she has delivered? She's just delivered once, isn't it? In that she delivered twins. So it will be para 1. She delivered a healthy full-term twins 4 years ago. That is all they have told. So she will be para 1. Okay. Para 1 and living 2. So this will be her obstetric score. So gravida, present pregnancy crossing the period of viability will not make it to count under para. Only if she has delivered, it will come under parity. So parity is nothing but deliveries. Total number of deliveries the patient has had after the period of viability. If it is before the period of viability, she has expelled it, then it will come under abortions. Isn't it? As simple as that. So if the termination has happened after period of viability, she'll come under para. Termination has happened before period of viability, it will come under abortions. As simple as that. So it is gravida to para 1. So don't get confused between the weeks. Now pregnancy, however, even if she is 39 weaker, it will be only gravida. It is not going to come under para. Okay? Understood? Next question. A 30-year-old primary gravida at 34 weeks of gestation presents with mild headache, elevated blood pressure. Now that you know headache and blood pressure, there is imminent signs and there is BP high. That means she is a preeclampsia. Okay. So preeclampsia we say because already headache is there. And laboratory evaluation reveals LDH is 700. Okay, LDH is 700 means what? There is hemolysis, isn't it? Hemolysis is happening. So LDH is raised. Platelet count is low. Okay, low platelets are there. And bilirubin is 1.5 raised. SGT and 180 and ALT is 140. So more than how much is considered as abnormal? Normal is less than 35. Okay. So normal value should have been less than 35. So more than double. That means more than 70 is considered as abnormal. Both of them are more than 70. So elevated liver enzymes also. Okay, so hemolysis, elevated liver enzymes, low platelets. Your diagnosis right here, preeclampsia with hemolysis, elevated liver enzymes, and low platelets. Let us see question again. Coagulation profile and renal function tests are within normal limits. There is no end organ renal damage. What is the most likely diagnosis? Acute fatty liver in pregnancy. So fatty liver in pregnancy, what will happen? There will be abrupt, very severe changes. There will be sudden onset. In fatty liver of pregnancy, there need not be low platelets, there need not be elevated hemolysis, LDH, or there need not be high blood pressure. So all of them would not go for fatty liver, and the enzymes levels will be very high. And HELP syndrome, yes, correct answer is HELP. We know they have given everything, hemolysis, platelet count they have given low, bilirubin is raised, and SGOT, SGPT is also raised. So it is a HELP syndrome. Intrahepatic cholestasis in pregnancy. So this is very common because of the progesterone. Cholestasis is there in pregnancy. Here there will be no low platelets, and there is no LDH raised, should not be there. Acute viral hepatitis, then they should have given you her serology, isn't it? HBsAg positive, HBe antigen positive. They should have given you her serology. Yes, all of you have given a correct answer. Yes, Danush is correct. The tense is the raise is very high. In fact, fatty liver acute damage, the raise is not in 180, 120 like that. It will be very high. Almost will be in thousands. The raises will be so high. The damage to liver is very high. Okay, next question. A 48-year-old woman presents with complaints of foul smelling discharge and spotting. Okay, there is foul smelling discharge and spotting. Cervical erosions are noted on per speculum examination. Okay, there is cervical erosion. In which age group cervical erosion is common? Yes, in early reproductive age group, cervical erosions are common. They will come healed back. Okay, not at this age of 48 years. Which of the following investigation would be most appropriate in this patient? Pap smear, yes, you have to do pap smear. Cervical biopsy, yes, for the erosions, you may have to do biopsy. Electrophoresis and HSV. HSV is herpes simplex virus, isn't it? So, do we have to do herpes simplex virus testing? No. Electrophoresis? No. We don't have to do this. So, this is wrong. Pap smear, correct. Cervical biopsy, correct. HCV testing. Do you want to do hepatitis C? No, wrong. What all answers you people have given me? C. Danush is the answer for this C. Yes, we'll see. Liquid based cytology. Liquid based cytology means what? Where we take the full brush smear and we'll put the stick inside the liquid and send full liquid in for testing. Not just the smear, the full liquid, everything. The testing capacity is more, or the accuracy is more with the liquid based cytology instead of pap smear. Okay, you can do liquid based cytology. Very good. Cervical biopsy, if abnormality, yes, you can do. You can do visual inspection. You can under acetic acid or lugol iodine, and you can do HPV DNA testing. If we do pap smear in the same sitting, we won't be able to do HPV DNA. But if we do a liquid based cytology in the same sample, we will be able to do HPV DNA testing. That is the advantage of LBC over the pap smear. Okay, so this is the correct answer. Pap smear, cervical biopsy, HBV DNA. Hepatitis B, again, we are not doing here, isn't it? So this is wrong. So correct answer, very simple question. This is based on the options. Ruling out is very easy in this question, isn't it? Next question. A 27-year... Okay, a 27-year-old woman presents with secondary amenorrhea for 6 months. Laboratory evaluation shows 2 elevated FSH levels, that is more than 40. That means she is ovarian failure is there, isn't it? Whenever elevated FSH is there, menopause. Okay, that too 2 sittings 4 weeks apart, more than 40, menopause. Okay, but she is only 27 years old. Menopause in this early is called as what? Premature ovarian insufficiency, isn't it? Which of the following serum estradiol levels support the diagnosis of primary ovarian insufficiency? So they have given you diagnosis. Yes, 27-year-olds raised FSH, it is primary ovarian insufficiency or premature ovarian failure. Okay, so this premature ovarian failure, what all other hormonal changes will be there? They're asking you about the estradiol, estrogen. What will happen to the estrogen levels? So ovaries over FSH is produced from the pituitary, isn't it? Pituitary is sending so much FSH for the ovary, which is having no follicles at all. There are no follicles. That is why it is sending, stimulating the ovary. Please produce some amount of estrogen, produce some amount of estrogen like that, isn't it? So it is trying to stimulate the ovary, the FSH. But there is, what will happen with the estrogen? Estrogen is produced from, isn't it, ovary? So now there is no estrogen production at all. That is why there is no negative feedback mechanism. There is no stoppage on FSH secretion. So will it be more than 200? Definitely not. Estrogen will be definitely reduced, isn't it? No. 100 to 150, again no. Less than 20. The FSH will be very high, whereas estrogen will be very low in case of premature ovarian failure. That is less than 20 picogram. Yes, very good. All of you have given the correct answer. Dhanush is asking about what you say, ovarian follicles, or you can say capacity, ovarian capacity, or you can say the follicle capacity. So it is indicator of the fertility. So what are the things that we see? Firstly, on hormonal testing, we see FSH. FSH is very high. That means reduced ovarian reserves. Then AMH. AMH is low. That means again ovarian reserve is low. On ultrasound, follicle count will be seen. Okay, if you can see good amount of follicles, then it is there. If follicles are less in number, reduced follicle count, then again there is reduced ovarian reserve. So all of them are the factors of ovarian reserve testing. Remember, of these, AMH becomes one where there is no time specific. Any time of the periods you can do. But FSH and follicular count, when we check, it is mostly checked on a time specific period. FSH is usually checked in the early phases, that is in your follicular phase, that is in the after 2 days, day 2, day 3 of the cycle. And follicle count is monitored over the cycle period. How many follicles have come up in this cycle, like that. Okay, so these two are time specific, whereas that is not so for the AMH. These are the ovarian reserve testings. So here we come with the last question, I think, of the day, from OBG side. Still you have medicine, surgery and patho, I think, still left. So this is a 24-year-old primary gravida, 38 weeks of gestation, undergoes ultrasound as shown in the image below. Okay, so when you do a scan, this is the image that is shown. What is the most likely diagnosis? Yes, tell me, what is the diagnosis? Very easy question, isn't it? Okay, Sri Lakshmi, I think the answer was for the previous question, no? Yes, Danush gave the correct answer so many times. Enough, Danush, I saw your answer is correct. I have given you a picture with the pelvis. They can give you a picture in the scan ultrasound image where you can see the cervix down here and the baby's foot and the image buttocks here and the foot facing the face of the baby. Okay, they can give you ultrasound image also. I'm sure you'll be easily able to diagnose this. Frank breach or an extended breach. Yes. Tanush is read, full prepared for the exam. Very all the best. Yes. Very good. Excellent. Everybody gave the correct answer. Yes. So complete breach means, complete means universal flexion, isn't it? Whenever the baby is in, all the joints are in flexion position, it is called universal flexion, and that becomes a complete breach, which is very good for rotation. Okay. Next, coming to frank breach. Frank breach, what happens? The knee joint is extended. As in this image, the knee joint is extended, rest all are flexed. Okay, knee joint is extended. Footling presentation, what happens? The hip joint and the knee joint both are extended. The foot comes down. Hip and knee joint are extended. Knee presentation, what happens? The knee joint is flexed, whereas the hip joint is extended. Which easily you can do just by putting your own body structures like that, isn't it? So this is really easiest question. You should answer this very easily, and everybody has answered also. So remember, these exams are just to prepare you, give you a good motivation. We don't want to give all difficult questions and demotivate you, or all give easy questions and tell you are very good, no need to study. So we are just trying to prepare you. All the results is dependent on you, how you focus these last days. So prepare very well for these last days and you will be able to ace in your exams. Okay, so don't worry about the results, just prepare, you will do good. Okay, as I can see, all of you have read well, and the only thing is how you concentrate on those 3 hours. And don't miss on at the next Sunday grand test also, the third grand test. Please do it well. And as I can see, the algorithm, everybody has improved from what you have done, but definitely there is more place for improvement, which will happen with your revisions. Okay, all the best, students.
Okay, so hi everyone. We are done with the first two sessions, and if you are still here with us, I'll be very brief in the discussion of the questions that will be there in my share, and I hope you'll be getting what all you want from this session. Please go back very quickly and get back to your notes and whatever you are revising. The time is really less now, but be focused and be determined. You'll be able to solve majority of the questions if you keep your mind cool. Okay. And don't really be bothered by the performance in any of these grand tests right now. Just keep focused on revising whatever is at hand till the NEET examinations. Okay. All right. So let's start with the first question that we have today. So we have a 48-year-old woman who presented to us with who underwent lumpectomy which was followed by whole breast irradiation for ductal carcinoma in C2. Her tumor is ER positive with comedal necrosis and closed margins. Don't know that have mic. It's saying it's dark mic off. It's on. Just a second, but I think the voice is echoing. Just give me a sec. Yeah, now it's off. Is it okay now? Am I audible to everyone? And okay. So we have a 48-year-old woman who undergoes lumpectomy followed by whole breast irradiation for ductal carcinoma in situ. Her tumor is ER positive with comedal necrosis and closed margins. Okay. Which of the following statements best justifies addition of tamoxifen in these patients? So what do we have basically? A patient who underwent breast conservation surgery, lumpectomy was done, which was followed by radiotherapy. And what did we find after that? We found that she was having a tumor which was ER positive. There were comedal necrosis. That means it's a high-grade DCIS you're basically dealing with. And we also had closed margins. So these are the two things which will be indicating high chances of recurrence. This is what the question is going to tell you, okay? Comedal necrosis, closed margins are given to tell you that this tumor has a high chances of recurrence. Now, what is the true statement or what best justifies the addition of tamoxifen in these patients? Let's look at the options. It's a good question. It can be asked in the exam. Tamoxifen reduces the ipsilateral and contralateral breast cancer recurrence in ER positive DCIS. That's a true statement. So it has been found in the latest NSA BP4 trial that it reduces the recurrence ipsilateral side 69% and the contralateral breast by 45%. Recurrences are reduced. Anyways, this tumor has a high chances of recurrence. There is comedal necrosis as well as closed margins. So you will definitely be using. So that's a true statement. Then tamoxifen benefits all patients with DCIS irrespective of estrogen receptor status. This is not true. So tamoxifen will only benefit those patients wherein they are having ER receptor positive. Basically, what is tamoxifen? It's a selective estrogen receptor modulator. If you don't have an estrogen receptor positivity on what is it going to act? There is no target area now. So therefore, it is beneficial only in those who are ER positive. This is not a true statement. Tamoxifen replaces the need for radiation therapy after lumpectomy in DCIS. This is not true. So their modes are different. Basically, radiotherapy is meant to take care of the microscopic residual disease which are left behind. When you give tamoxifen is meant to prevent the estrogen driving the further growth that is going to happen or increasing chances of recurrence. So none of them is going to replace. So neither radiotherapy is going to replace tamoxifen nor tamoxifen is going to replace radiotherapy. Radiotherapy is mandatory after lumpectomy or breast conservation surgery. There is no replacement of radiotherapy. So this is not true. Tamoxifen has no role once the radiation therapy is given. Not true. I told you if it's an ER positive, hormone receptor positive tumor, you will be giving tamoxifen, especially this is a premenopausal female. So your answer is going to be option number 8. So this is a wonderful question. You should be getting through with the concepts of this question. Okay, next. Successful intraperitoneal placement of the instrument shown below is best confirmed by which of the following? First of all, what is this instrument we are looking at? This is a Veris needle. Okay, this is Veris needle. Now, what is the options? What are the options stating? Abdominal pressure reading more than 15 millimeters of mercury. No, the initial insufflation, once you have through the peritoneal cavity, it is going to be less than 8 to 10 millimeters of mercury. And this is what is the objective verification of the intraperitoneal placement. This is a good sign. Okay, this is one of the good confirmatory sign. Not as high as 15 millimeters of mercury. Return of bowel contents and aspiration, not true. This is indicating that you have entered the bowel. So you have perforated the bowel. This is not true. Hanging drop test showing inward flow of the fluid. Absolutely. Why would there be inward flow? Because of the negative pressure in the peritoneal space. It is going to suck in the saline drop that you are going to place. So this is one of the methods of confirmation. Which are the other method? If you aspirate, there is nothing that comes out. That is again a positive test. And also if there is a free flowing saline. So these are the 3-4 tests. Objectively, which is the best one if you are asked, because that will be the low pressure that you get. So less than 8 to 10 millimeters of mercury. Immediate high flow CO2 insufflation will not be done. Why? Because you're going to first confirm you have entered the peritoneal cavity and it is not in the false space. Okay, so you will not immediately start insufflating high pressure CO2. Okay, so the answer is going to be hanging drop. All right. Okay, next question. Which feature of the following instrument helps it hold tissues securely during the surgery? Okay, so basically this is not a very good depiction what we were wanting to do basically. So this is a incision that you can see. It's a coccus incision that has been placed. It's a typical location for the thyroid surgery, but we were trying to show you this basically. So we were trying to show you a Jawl's thyroid retractor. Okay, Jawl's thyroid retractor. This is how it is going to be in the examination. So basically, what do you have here? You have the clips which are there at the edge, which are curved and they can hold the tissue margins. Once you release the clips from here, they're going to be holding the tissue margin. You fix the clips again, and then you can move the screw to adjust how much of separation do you need. It's a self-retaining retractor, so retraction is there. The other assistant is going to be basically free. So what is the answer here? The ends will be curved and hooked. This is what we were trying to ask you. Okay. All right. Next question. A 72-year-old man with a known abdominal aortic aneurysm is being evaluated for possible endovascular repair or EVAR. Okay, all right. On examination, lower limb pulses are absent. So what are we basically looking at? We are looking at a aortoiliac disease. Okay, we are looking at an aortoiliac disease. DSA appears to show a relatively small aneurysm lumen. So we have done a digital subtraction angiography. It is showing you a small lumen. Which of the following statements is most appropriate regarding the assessment of this patient's aneurysm? Now, which is the most appropriate is being asked. Okay. DSA is the best modality to assess the aneurysm size. Not true. Why? Because in cases of abdominal aneurysm, like we have here also, we are going to have what? Abdominal aneurysm usually are associated with a mural thrombus. Okay, so there is going to be a mural thrombus which is going to be stuck close to the inner wall of the inner wall of the aneurysm. Now, when there's a thrombus stuck to the inner wall of the aneurysm, what is going to happen? You're going to give in a contrast which is given in cases of DSA. So basically, it's a study which basically tells you about the lumen. Now it is going to tell you this space. It is not going to tell you the entire lumen and entire size of the aneurysm. So therefore, it is going to underestimate the size. DSA is basically the study of the lumen. It's a luminography. Okay. What is going to tell you the exact size, which is going to include the size of the thrombus, mural thrombus as well, is going to be CT or CT angio. That is what is preferred. So therefore, computed tomography scan is best for assessing aneurysm morphology. Let's look at the other options also. DSA accurately reflects the true aneurysm diameter even in the presence of mural thrombus. Not true. It underestimates the diameter of the aneurysm in presence of mural thrombus because it is only going to tell you the patent lumen which is available where the contrast is moving. Okay. Lower limb pulse absence rules out the suitability for endovascular repair. Not true. Endovascular repair suitability depends upon a lot of things. The anatomy, what is the proximal neck diameter, what is the distal diameter, what is the diameter of the abdominal aorta. So it is dependent on a lot of things, proximal zone, landing zone. So it is not mainly dependent only on the fact that the pulses are absent. So you don't directly rule out EVAR just because the peripheral pulses are absent. Okay. So your answer is going to be option number B. All right. Okay, next. A 25-year-old victim of vehicle collision injury is brought to the emergency. There's a vehicle collision injury which has happened. He is being brought to the emergency with complaints of acute pain in the abdomen. The CMO informs you about his vitals. Blood pressure is 70 by 50. So basically, there is hypotension. This is one thing which is there. Okay, all right. Pulse rate is 140 per minute. That is, the patient is tachycardic. BP is not responsive to fluid challenge. You evaluate the patient and find bruising over the left flank with diffuse abdominal tenderness. Very important hint. X-ray suggestive of left lower rib fractures with no evidence of pneumothorax or chemothorax. Left lower rib fractures. So what is the most likely thing that has happened? There is a splenic injury that we are basically looking at. We are looking at a splenic injury. Now, in cases of splenic injury, what is happening here? There is a bleed which is ongoing currently. So he has hemoperitoneum. So if the option would have said that along with resuscitation, do a fast, it would have been a correct statement initially. But what does it say? What does it say? Most appropriate course of action. Will you do a diagnostic laparoscopy? There is no time. The patient is deteriorating. Despite of giving IV fluids, the patient is not improving. The blood pressure is tanking below, and therefore you will not be going for any further diagnostic approaches. Okay. Hourly vital monitoring of the patient after starting NORAD? No, you will not be doing an hourly monitoring. You will not be going for CCT abdomen because the patient is hemodynamically unstable. Very important. The patient is hemodynamically unstable, dynamically unstable, right? And if he's unstable, the CCT abdomen gets ruled out. You only do it when the patient is stable. DPL was a thing of the past. We don't usually do DPL nowadays. And urgent laparotomy and splenectomy. So you will immediately open the abdomen, see where the bleed is coming from. You will identify the splenic injury. What is the grade of the splenic injury? Most important thing, because the patient is hemodynamically unstable, he is deteriorating continuously, you will avoid going for splenic artery embolization. So generally we do embolization when the patient is stable and you can intervene in a fashion wherein the patient is not going to deteriorate further, right? But if there is a continuous deterioration, what you do preferably, you'll go for a splenectomy. So that is the source of the bleed. Urgent laparotomy and splenectomy will be done so as to salvage this patient. Okay. Okay. Next question. A 24-year-old man is brought after a road traffic accident. He was unconscious at the scene. CT scan shows a large right temporoparietal. So there is right temporoparietal EDH which is there in the patient with midline shift. So there is a characteristic midline shift also. It's a large right temporal EDH. On examination, the right pupil is dilated and it's non-reactive. He has weakness of the right, very important, right-sided EDH only and right-sided weakness only, which is present in both the limbs. Which of the following best explains the ipsilateral hemiparesis? So what has happened in this patient? There is a big EDH. So if you imagine here, there is a big EDH which is present here, big EDH, which is causing what? Which is causing pressure onto the left side. Usually what is going to happen? There is going to be right-sided uncal herniation. That is what has happened, and he is already having a third nerve involvement, which is causing the dilatation of the right pupil. But this EDH is really large. It is pushing towards the left. It is pushing. It's causing a mass effect. It is causing a midline shift. So what is happening here? There is this left cerebral peduncle. So left cerebral peduncle has now herniated and is pressing against the left tentorial edge. It is pressing against the left tentorium. When it is pressing against the tentorium, what is going to get involved? There will be involvement of the left corticospinal tracts. Left corticospinal tracts will be involved. What is going to happen? It is going to cause right-sided hemiparesis. Right-sided weakness will be present. And that is exactly what is happening in this patient. So there is going to be involvement of the contralateral tracts. So compression of the contralateral corticospinal tracts at the tentorial edge. That is what has basically happened in this patient. What is this called as? This is characteristic called as Kernohan's notch phenomenon. Very important. Kernohan's notch phenomenon. All right. Okay. So that was the concept behind this question. Next. Given the above thyroid scan, what is the most likely risk of malignancy? So what are you looking at basically? you're looking at a hot nodule. Okay, see, the uptake is comparatively more here. It's a hot nodule. What are the chances of malignancy in hot nodule? We roughly say 1 to 3% chances of malignancy are there in hot nodule, whereas in cold nodule we say roughly about 15 to 20% chances of malignancy are there. Okay, so here the answer is going to be 1 to 3%. It is asking about the risk of malignancy, right? Okay. A 45-year-old man presents with 45-year-old rapidly progressive painful swelling of the submandibular region. There is foul smelling breath. There is dysphagia. There is elevation of the tongue. Very important. Swelling is firm and brawny with no obvious pus collection. Which of the following best explains the mechanism of airway compromise in this condition? What is the condition that you're looking at here? This is characteristically Ludwig angina that you're talking about, basically. Why? What is this? You're having a painful swelling, okay? So there is a swelling or a cellulitis which has happened in the floor of the mouth that is causing edema. So there is a cellulitis, there is inflammation, edema deep to the mylohyoid, which is causing the posterior tongue displacement, and that is what is basically leading to the airway compromise in this patient. Okay, that is what you should be knowing about this patient. Next, a 4-year-old. Okay. Yeah. A 4-year-old child presents with recurrent episodes of painless, 4-year-old child, okay, that's a 4-year-old patient, recurrent episodes of painless, massive lower gastrointestinal bleeding. Here itself, the diagnosis is pretty evident. Until and unless proven otherwise, a 4-year-old child who has recurrent episodes of painless, massive lower GI bleed, what you should be suspecting? You should be suspecting a Meckel's diverticulum, okay? That is what should be the first doubt that should be in your mind. Meckel's diverticulum. Okay, let's look at the question further. Intraoperatively, also the following finding is seen. You can see a blunt end that is visible. Blind ending pouch is visible. The lesion is excised based on the image and clinical scenario. Which statement best explains the pathology responsible for bleeding? So what is present inside the Meckel's diverticulum? You have the heterotopic mucosa or the ectopic mucosa which is present. Which is the most common ectopic mucosa that you have? The most common one that is present is gastric mucosa. You can also have pancreatic. Gastric mucosa will secrete acid, and that is what is going to cause a ulceration of the adjacent ileum, and that is what is going to lead to bleeding. So this is what the mechanism is in these patients. 2% of the population 2 feet from the ileocecal wall, and 2 types of mucosas you can see. You can see a gastric mucosa and you can see a pancreatic mucosa. Okay, so that is the answer for this question. Next question. A trauma victim following a road traffic accident presents with subcutaneous emphysema. Okay. On chest examination, breath sounds are absent on the right side and patient is hemodynamically unstable. Absent breath sounds, hemodynamically unstable patient. What is the diagnosis that you're going to make? This is characteristically tension pneumothorax. Okay. This is This is a tension pneumothorax. Okay. What are you going to do in these patients? There is no other thing that has been mentioned. His GCS has not been mentioned. So we will be going by the XABCD protocol. What is the most appropriate immediate management? So there is no immediate indication for intubation in this patient that has been mentioned in the question. Would you be going for a bedside fast examination? No, the patient is hemodynamically unstable and characteristically it is having a presentation of tension pneumo. So what are you supposed to do? Would you be going for rapid sequence intubation plus positive pressure? Absolutely no. Already there is a shift which is happening, mediastinal shift which is happening in this patient. The lung is collapsing. Would you be giving more positive pressure? No. IV fluid resuscitation? No. You will be doing an immediate needle decompression where in the 5th intercostal space. So nowadays needle decompression is also done in the 5th space. We don't do it anymore in the 2nd space. Okay. So this is the characteristic question. So earlier they used to give you a GCS value of less than 8, wherein you have to intubate the patient. So that is the standard criteria. We know that as the GCS is less than 8, that makes a criteria for intubation. Okay. Here it is not mentioned. So definitely the next line of treatment is going to be immediate decompression that we're going to offer. Next question. A 37-year-old woman complains of dysphagia, and has an increased median integrated relaxation pressure and 100% failed peristalsis with no pan-esophageal pressurization that is seen on manometry. Which of the following is her diagnosis as per the Chicago classification, that is for the esophageal motility, fourth version that we have, the Chicago 4.0 classification. So this is something that you should be knowing. We have discussed the Chicago classification in our revision sessions as well. So when you have increased median IRP with 100% failed peristalsis, but there is no pan-esophageal pressurization, that is what classifies as classic type 1 achalasia. Okay, so you should be knowing these parameters. Let's quickly discuss them once again. So type 1 is the classic variant where you have elevated integrated relaxation pressure. That means the esophagogastric junction is not relaxing. That is increased. There is 100% failed peristalsis and there is no significant pan-esophageal pressurization. Type 2, you have both elevated IRP plus 100% failed peristalsis, but along with it, you have 20% or more swallows with pan-esophageal pressurization. And type 3 is the spastic variant where you get premature or spastic contraction in more than equal to 20% of the swallows. Okay, so that is the three variants that you should be knowing about. The Chicago 4.0 classification for esophageal motility disorders is very important. It can be definitely asked in your exam. Next, a 39-year-old male presents with upper abdominal pain. There is fever, there is pruritus and jaundice, and weight loss. So there are features of cholestasis that you can see. There is pruritus and jaundice. ERCP reveals the following finding. What you can see characteristically, there is a beaded appearance that is visible here. So this is a characteristic presentation of what? This is a characteristic presentation of primary sclerosing cholangitis. You have a young male presenting with a cholestatic pattern along with the ERCP characteristically giving you a beaded pattern. There are multiple short segment strictures which are present. This is a characteristic hallmark feature which you're going to get in cases of primary sclerosing cholangitis. Okay. All right. Next question. A patient with sacrococcygeal defect following the excision of a pilonidal sinus undergoes reconstruction using a Limburg flap. So there's a reconstruction being done with a Limburg flap. Which of the following correctly describes the characteristic angles of the flap? So what's the Limburg flap like? It's basically a rhomboid flap, okay? So it's a rhomboid flap. What are the angles of the rhomboid? So you have 120-degree angles as well as you have 60-degree angles, basically. So rhomboid flap is basically to flatten off the effect which is there because it's present at where? It's present at the natal cleft, okay? So that's why we want a rhomboid flap to be placed there. What are the angles for the rhomboid flap? 60-degree and 120-degree. These are the characteristic angles that should be there. That is what are there in case of a rhomboid flap. Okay, beta? All right. So this is what is the Limburg flap that you're talking about. This is a different place that you're putting it. Okay. All right. Next question. This is a repeat question that has been asked. I think it was asked in INI-CT. What is the most likely diagnosis depicted in an image? So there is no confusion when you have this kind of an image. So what you're looking at, there is gangrene which is present here. So there is gangrene. What is missing? There is no clear line of demarcation. There is no clear line of demarcation. Okay. All right. So there is no clear line, number one. The first thing. And second thing, what you're having is swelling which is visible. That swelling or edema or inflammation, that is indicative of infection. So whenever you have, there is gangrene, or when you say tissue necrosis plus infection, this is what makes the diagnosis of wet gangrene. Okay, this is what is characteristically wet gangrene, generally seen in cases of diabetic patients. Okay, and what is a surgical emergency? Is a dry gangrene surgical emergency or a wet gangrene? It's a wet gangrene which is a surgical emergency because that part is basically acting as what? It is acting as a poison drip. Why? Because the blood flow to the area is not there. There's a rapid proliferation of the bacteria which is happening there, which is continuously releasing toxins into the system. So the patient can collapse very quickly with a wet gangrene. So therefore, urgent management. So basically, what do we say? The treatment is going to be source control in these patients. So you can have a further question. What are you going to do? Source control, basically. So debridement might be needed in these patients. Okay. So what is the most likely diagnosis here? The diagnosis is going to be wet gangrene. Got it? Okay. Next question. Which of the following is most common procedure for grade 3 internal hemorrhoid? So there is prolapse, which has to be manually reduced. Now, grade 3 generally, so 3 and 4, both of them are managed with open hemorrhoidectomy. Okay, so you have to go for open hemorrhoidectomy. That is what is supposed to be done. So the answer is going to be open. Now, rubber band ligation is preferably done for grade 2. So for grade 2, banding is preferred as compared to sclerotherapy. Stapled hemorrhoidopexy is done for internal hemorrhoids wherein there is circumferential prolapse. So preferentially done when there is a circumferential prolapse. Okay, and hemorrhoidal artery ligation also. But the problem with these procedures is that there is a high chance of recurrence. So preferentially, we always do most common surgeries as most common procedure. We'll do a open procedure, which is the one that we do. We do a Milligan-Morgan open hemorrhoidectomy done. Okay, so this is what you should be knowing. Okay, next. A 40-year-old woman presented at the clinic with symptoms of, so 40-year-old woman is there with the symptoms of upper abdominal pain without any distinct location. An incidental finding of a lesion in the right lobe of the liver during abdominal ultrasound was done. Okay, noted. CT scan revealed a well-defined hypodense lesion in the liver. There was peripheral enhancement with asymmetrical nodular appearance. What is the most probable diagnosis? So whenever you have peripheral enhancement with nodular appearance, what are we talking about? We are talking about characteristically hemangiomas. So in one of the important discussion sessions that we had for revision, I had a detail. Somebody had asked me about the three phases of the triple phase CZT. We had talked about it, okay? So in the arterial phase here, there is going to be peripheral enhancement. So you get peripheral enhancement that is noted as mentioned in the question. Whereas in the delayed phase or the venous phase, what do you get here? You get centripetal fill-in, right? So the contrast is going to be filling in. So you get centripetal fill-in in this case. So two things will be there. There will be peripheral enhancement and centripetal pooling or filling in that you're going to see in cases of hemangioma. So this is hemangioma. What do you get here in cases of HCC? You get in the arterial phase, there is enhancement that you note. There is enhancement that is seen, rapid enhancement, followed by what is there in the venous phase. There is washout that is noted here. That is a feature of hepatocellular carcinoma. Focal nodular hyperplasia, we know you get a characteristic central stellate scar. So stellate scar will be there in these cases, okay? So that is your diagnosis, it's hemangioma. Next question. A 15-year-old boy presents with sudden onset scrotal pain that resolved spontaneously after a few hours. So probably a torsion happened, it detorted and it resolved, okay? Examination is normal. 2 weeks later, he develops severe scrotal pain during physical exertion. So once again, there is a repeat of the torsion episode. At exploration, the testis is found to rotate freely within its covering without fixation to the scrotal wall. So there is no posterolateral attachment that is usually present, it is missing. With which underlying anatomical abnormality most directly explains both the episodic nature of pain and the mechanism precipitating torsion. So what are we looking at? We are characteristically looking at the bell clapper deformity that we have here. There is high investment of the tunica vaginalis of the sphenotic cord. So it's basically because of the high attachment that is what is causing the free hanging of the testis, and therefore there is continuous torsion and detorsion of the testis which is happening here. Okay, all right. Regarding renal angiomyolipoma, which of the following statements is incorrect? पूछा है उसने, ठीक है? Okay, so क्या क्या है इसमें? Blood vessels हो गए बेटा, myo is your muscles and your lipoma is fat. So there is macroscopic fat which is there. So AML can be definitely diagnosed on cross-sectional imaging due to the presence of macroscopic fat. True statement. AML is the most common cause of spontaneous retroperitoneal hemorrhage. True. What is it called as? This is called as the Wunderlich syndrome. Very important. This is also something that is asked. We frequently discuss it during our discussions. Everolimus is indicated for large multifocal AMLs in patients with tuberous sclerosis and LAM. Very important. So what are the pathways that are involved? They are the mTOR pathways. So we are going to use an mTOR pathway inhibitor, which is the one we use everolimus. That's a true statement. Selective renal embolization is the treatment of choice for asymptomatic. No, this is not true. What are you going to do? Basically, you are going to observe, right? You have to monitor these patients. Serial surveillance is what is active surveillance is what is going to be done. So this is the answer. Incorrect has been asked. We don't really go in for angioembolization in cases of small asymptomatic AMLs. Okay. All right. Next. A 1-month-old infant undergoing emergency surgery requires internal jugular vein cannulation for central venal access. So basically, IJV को आपको cannulate करना है. बच्चा कितना है? 1 महीने छोटा बच्चा है. Which technique is recommended to increase the first pass success and reduce the mechanical complications during catheter placement? तो आपको first pass में ही आपको IJV में डालना है. So what are you supposed to do? You will be doing it with the help of a real-time USG guidance. Okay, आप anatomical markings पे भरोसा नहीं करोगे. You will not be believing the landmarks. Real-time USG guided, you will be looking at both the structures nearby. IJV, carotid artery, दोनों को पास देख के, then slowly you will be assessing the diameter also to real-time USG के मदद से, and then you will be noting it whether you have entered into the IJV. So it is going to be done with the help of real-time ultrasound. Doppler guidance, no. Fluoroscopic guidance is going to tell you exactly. So where exactly is the tip? Catheter hai kahan par? That is what the fluoroscope is going to tell you. But the first pass, it is going to be done with the help of a ultrasound only. Real-time ultrasound guidance. Okay? All right. A 60-year-old man with a history of COPD is undergoing general anesthesia for hernia repair. 60-year-old man. During laryngoscopy, the clinician uses the blade as shown below and places its tip into the vallicula to visualize the vocal cord, which is the blade, the curved blade. This is your Macintosh blade that is used. Okay, Macintosh blade. What is the most likely mechanism by which this blade improves the glottic view? Does it cause direct lifting of the epiglottis? No, this is the case with the Miller's blade, not with the Macintosh. Macintosh causes what? It is placed in the vallicula. So space between the tongue base and the epiglottis, basically, it causes the indirect lifting. So upward and forward movement is done. It causes indirect lifting of the epiglottis by engaging the vallicula. So basically, it pushes the tongue also side. So among the options, the best answer is going to be the B, but it could have been better if it was indirect lifting of epiglottis. That was a better answer. Okay, indirect lifting of epiglottis. All right, next question. A 30-year-old healthy male develops progressive bradycardia and hypotension 35 minutes after he was given spinal anesthesia. Okay. Sensory block has extended to the level of nipple line. What is the nipple line? T4 के level तक sensory block आ चुका है. Which factor is most strongly associated with impending cardiac arrest in this setting? T4 के level तक sensory block आ गया, मतलब आपका spinal block जो है कहाँ तक चला गया? T4. वो cardiac accelerator fibers कौन से होते हैं बेटा? Cardiac fibers कहाँ से आते हैं? Sympathetic fibers T1 to T4. तो अगर आपका स्पाइनल ब्लॉक T4 तक चला गया है एंड देयर इज अ फर्दर ब्लॉकेज, तो आपके कार्डियक फाइबर्स इन्वॉल्व हो चुके हैं, सिंपैथेटिक सप्लाई इन्वॉल्व हो गई, बिकॉज़ स्पाइनल ब्लॉक controls the blocks, all the sympathetic flow beneath where it is given, and therefore basically you're now dealing with the case of high spinal block at T4, right? This is what is basically understood. Okay, all right, next. A 32-year-old male presents to the ER after high-velocity road traffic accident where he fell on his outstretched hand. Outstretched hand पे गिरा, high-velocity injury थी. Wrist pain था, swelling थी. On examination, there is tenderness over the dorsal distal radius. Very important first thing. Swelling and limited wrist motion. X-ray was taken. What is the most likely diagnosis? So what is the X-ray going to show you? क्या दिख रहा है X-ray के अंदर बेटा? इंट्रा आर्टिकुलर फ्रैक्चर दिख रहा है पहले तो, जॉइंट के अंदर इंट्रा आर्टिकुलर है फ्रैक्चर, ठीक है, इंट्रा आर्टिकुलर. दूसरा क्या दिख रहा है? इट इज इन्वॉल्विंग द रेडियोकार्पल जॉइंट. इट इज इन्वॉल्विंग द रेडियोकार्पल जॉइंट. दिख रहा है आपको? रेडियोकार्पल जॉइंट का क्या हो चुका है? रेडियोकार्पल जॉइंट हिल गया अपनी जगह से. देयर इज सबलक्सेशन दैट इज विजिबल along with the involvement of, there is a dorsal rim that is involved. So what is this characteristically? Dorsal rim तक fracture, dorsal subluxation of the fragment, intra-articular fracture, there is subluxation of the radiocarpal joint. All of these are hallmark features of Barton's fracture. Subluxation dorsal, so it's the dorsal Barton's fracture, that is what is visible here. Okay, all right. A 32-year-old typist is reporting tingling and burning in his thumb, index and middle finger. Supply, which is the nerve, median nerve. बाकी बची हुई दो में कौन सी होती है? Ulnar nerve. Especially at night. He frequently drops the objects. The following test was done on him. कौन सा test है बेटा? What is this test? It's the Fallon's test. कौन सा test दिख रहा है? Fallon's test. 60 सेकंड तक हम फ्लेक्स करके रखेंगे ऐसे, उसके बाद सिम्टम्स अगर प्रेसिपिटेट हो रहे हैं, so like this is what is going to compress the median nerve. Basically carpal tunnel syndrome जैसा presentation. So this is what is the nerve more likely involved. That is what is tested in Fallon's test. Okay, all right, that's the question. Next. A 25-year-old male came to the hospital outpatient department with a history of his 25-year-old low back pain, which was radiating to the left leg. He reports that the pain worsens with prolonged standing and improves with rest. Very important. On physical examination, a visible step is noted above the sacral crest, and the straight leg raising test is also positive. X-ray was done. So visible step itself is giving you a hint. We are dealing with a case of spondylolisthesis, and vertebra has moved. So X-ray has revealed the anterior displacement of the L5 vertebra over the S1 common side. Okay. Which of the following types of spondylolisthesis is most likely explained or is present in this patient? Young patient generally has, which is the most common type of spondylolisthesis. If we talk about in young patients, it's the ischemic type of spondylolisthesis. So you have to know one point here: young age patients, the most common variant that we talk about is spondylolisthetic. There is no trauma, so there is no traumatic variant. Degenerative is seen in the older patients, and dysplastic is generally seen in children and in adolescents. Okay. So that is where you get those variants, but this is ischemic spondylolisthesis. Next. A 28-year-old woman presents with intermittent painless hematuria, okay, left flank discomfort. Doppler ultrasound reveals the compression of the left renal vein. Compression of this vein is most classically occurring between which two structures in the nutcracker? So the examiner has made it really easy for you. They directly mentioned it's a nutcracker syndrome. So where is it getting compressed between the SMA and the abdominal aorta? It gets compressed between superior mesenteric artery and abdominal aorta. What is the problem which is happening because of the compression? Because the left renal vein is compressed, the pressure in the system is going to increase, and that is what is going to cause hematuria. There is going to be blood which is going to be coming in the urine because of venous hypertension. Okay, so that is what is this question, that there is a compression between SMA and abdominal aorta. Okay. A 50-year-old woman underwent superficial parodontectomy for a benign parotid tumor 6 months ago. Okay, the superficial parodontectomy hui hai. Based on the finding demonstrated in the video and the patient's surgical history, what is the most likely cause of this condition? What is happening? So patient is chewing or eating food, and while she's eating food, what is happening? There is sweating, and there is redness that you notice here. There is flushing that can be seen here. What is this syndrome? This is called as gustatory sweating. Gustatory sweating, also called as the Fraze syndrome. Fraze syndrome. So what happens here? Basically, the parasympathetic supply that was there to the parotid gland was basically damaged. There was injury which happened because while you were operating the parotid gland. And when there was regeneration of this parasympathetic supply, which was supplying the parotid gland, so basically they are accompanying the auricular temporal nerve, but there was aberrant regeneration. So basically, along with the gland, they ended up supplying the skin as well as the sweat glands. So what is going to happen when the patient is going to be chewing? There is going to be salivation. Along with the salivation, what is going to be happening? There is going to be sweating as well as there is going to be flushing in that area. So it is supplying the sweat glands as well as the blood vessels of the area. So it is because of the aberrant regeneration of the auriculotemporal nerve. Which fibers? Parasympathetic fibers. Okay. All right. So that's your question. Identify the type of cartilage. So what you can see here, beta, you can see that there is distinct chondrocyte nuclei which are arranged in a row, interspersed by a lot of eosinophilic space, that is the collagen fibers. Characteristic presentation: you have chondrocytes arranged in a row, interspersed with collagen bundles. Type 1 collagen. What is this cartilage? This is the fibrous cartilage. Where do you see it? We see it where? In the intervertebral disc, annulus fibrosus, pubic symphysis, and these are the areas where you generally find it. Okay. All right. Next. A 35-year-old man presents with progressive flattening of the foot arch and pain, which is along the medial side after prolonged standing, suggesting a structural problem. Dysfunction of which of the following structures is most likely responsible for the descent of the talar head and development of flat foot? So there are two things which is happening. what is causing the descent of the talar head? What stabilizes the talar head? Basically, the spring ligament. Basically, so spring ligament acts like a hammock and stabilizes the talus head so that it doesn't descend further. This is what is the basic mechanism. And the other one that is responsible for preventing the flat foot is tibialis posterior. So this is a passive stabilizer. Okay, this is a passive stabilizer that we talk about. And tibialis posterior basically stabilizes the medial arch. So this is a dynamic stabilizer, right? So these two are responsible for prevention of the flat foot. But here it is asking what is preventing the descent of the talar head. It's going to be the spring ligament. Okay, all right. Next question. A 45-year-old patient presents with ataxia, shooting pains in the legs, and there is absent ankle jerk. A video of the patient's pupillary examination is provided. So basically, what we were trying to give you is that we were trying to say that accommodation reflex was present, but you can see characteristically we could figure out that light reflex was not present. So light was being shown into the eye, but there was no light reflex that was visible. There was no constriction of the pupil. So what is this called as? This is the Argyll-Robertson pupil. What is the condition? There is sensory ataxia, there is shooting pain along with the absent knee jerk. This is the condition that we call as tabes dorsalis, right? Which is the tracts which are involved. It's the dorsal column which is involved. Where do you get it? In tertiary neurosyphilis, okay? So this is basically the concept. Video was trying to tell you about the Argyll-Robertson pupil, okay? Presence of accommodation reflex, but the loss of light reflex. Right, next. During the thoracocentesis, precise knowledge of the intercostal neurovascular anatomy is critical to avoid the complications. Which of the following statements about the intercostal neurovascular bundle is incorrect? पूछा है उसने, ठीक है, okay. How does the neurovascular bundle proceed? It courses between the intercostal as well as innermost intercostal muscle. Absolutely true. It follows the VAN hierarchy, superior to inferior. That's the hierarchy it follows. That's a true statement. It runs unprotected along the midpoint of intercostal space. No, it runs in the costal groove in the superior cartilage, okay, superior rib. So basically, it is not at the main point in the intercostal space. So therefore, inferior groove में costal groove में जाती है inferior surface. So therefore, हम डालते कहाँ से हैं? Superior surface. So that's what we know. And lower intercostal nerves become thoracoabdominal. So that is true. T7 to T11 become thoracoabdominal, and T12 is your subcostal nerve. Okay. So which is the incorrect one? Option C, that it runs unprotected. Runs actually protected in the costal groove. All right. So that is the answer here. Next question. Identify the type of blisters in the image. So what is noted along with the blisters, beta? You can see that there is hyperemia or there is inflammation that you notice. Do you notice inflammation once the patient is dead? No. So basically, it is not post-mortem. It is the ante-mortem burn where you're characteristically going to notice these kind of blisters along with the hyperemia. Okay. All right. Next question. During autopsy, a suspected manual strangulation case in a 45-year-old victim, there was a fracture of the greater cornu of the hyoid bone, which was found with inward displacement of the fragment. And so basically, this is the fragment, it was displaced inwards, and periosteum was torn outside on the outer side. Which type of the hyoid fracture most commonly is consistent? So inward displacement, periosteal tearing is on the outside. This is characteristically which type of fracture, beta? It is the adduction fracture that you are talking about. And when there is outward displacement and inward tearing of the periosteum, that is your abduction fracture. So this is the characteristic adduction fracture of the hyoid that you are basically talking about. Next. A 45-year-old farmer, because of the manual strangulation, because of the pressure that you are putting, that is what is causing the fracture of the hyoid bone. A 45-year-old farmer presents with speckled brown pigmentation on the skin, speckled brown pigmentation on the skin flexures, temples, eyelids, along with the transverse white bands on his nail. तो जो पढ़ चुके हैं बेटा उनको immediately समझ में आ चुका होगा किसकी बात हो रही है. We are talking about the arsenic poisoning. Let's read further. तो ये तो हमको दो चीज समझ में आ गई. ये क्या मिल गया है आपको? Speckled brown pigmentation is characteristically raindrop pigmentation that we are talking about. and transverse white band on his nails are the Aldrich-Mees lines. Okay, so these are the Aldrich-Mees lines. He also complains of tingling and numbness on the hands and feet. What is this? This is the peripheral neuropathy. This is the peripheral neuropathy which is being mentioned here. Okay. His wife has been adding a white powder to the food for several months. So this is the arsenic that she has been adding. So this is chronic arsenic poisoning. So this is chronic arsenosis that we are basically dealing with. The skin finding, raindrop pigmentation, Aldrich-Mees lines. Burton's line and wrist drop feature of lead poisoning. Acrodynia pink disease is basically mercury poisoning. Okay, next. A surgeon under the influence of alcohol accidentally damages. He's under the influence of alcohol. He accidentally damages a major blood vessel during surgery, leading to the patient's death. This act is classified as he was under the influence of alcohol. He should not have been operating, but despite of the fact he knew that he was not fit for the operation, but still he went ahead and performed the surgery. This is called as criminal negligence. The skill was affected. In cases of therapeutic misadventure, what is going to be happen? Adequate skill was there, adequate precautions were there, but unintended adverse outcomes happened. That was your therapeutic misadventure. Dichotomy, we know, is fee splitting. You're taking commission for sending a patient to a different doctor. That is dichotomy. Okay, so this is criminal negligence. Next question. A 20-year-old man is bitten on his forearm by a snake. So we have a video of the snake. What can we see characteristically? It's a glossy, shiny skins, which is there of the snake, which is having characteristically white or yellowish bands, which are visible in the snake. What is this? This is a crate, right? This is the identification for a crate or an elapid. What's the kind of poison that you have here? It's a neurotoxic snake, okay? All right. What is the question stating? The patient is more than 1 hour away from the nearest hospital. All right. Which is the most appropriate first aid management initially? Will you apply a tight tourniquet proximal for the bite to stop the venom spread? No. So we never apply tourniquets. Basically, what we are trying to do is we are not trying to stop the arterial circulation because that can lead to the compromisation of the limb. So that is not anymore followed. So we don't apply tight tourniquets. Make an incision over the bite marks and suck out the venom. This is what is the script for the new episode of Nagin, not for the management that we do. We don't give incision, we don't suck out the poison, that we don't do. Okay, we're not shooting a video series here. Apply pressure immobilization technique. Yeah, this is what we use, PIT. Apply pressure immobilization technique with a compression bandage wrapped from the bite side upwards. So basically what we do, wherever the bite site is, we tear out a cloth or we use a compression bandage, roughly 50 to 70 millimeters of mercury. Only what you're doing is to stop the lymphatic spread. So lymphatic control is what we need. We are allowing the arterial and venous blood. Mainly the spreading is from the lymphatic. So that is what we are trying to control as and when you're trying to move the patient to the hospital. So we follow the right approach, reassure the patient. Limb mobilization is very important. As you immobilize the limb for a fracture, similarly, limb has to be mobilized, get to the hospital and treatment. So we follow the right approach. Wash the wound vigorously and soap and water, no. But remember, this technique is basically used for neurotoxin, not for cases when you have viper bites where there is local tissue injuries. Okay, so this is basically done for crate or the elapids, right? Okay, next. A child is brought to the hospital by a police officer with redness and tenderness around the anus. Okay, so there is a likelihood of a sexual assault which is there. So what are you going to try to confirm here? We are going to confirm the presence of semen. What is going to be present in the semen? There is going to be sperm. So what we do, we use picric acid here. So what are we looking at? We are characteristically looking at yellowish needle-shaped crystals. Needle-shaped crystals that you note. They are spermine picrate. So spermine picrate crystals which are present. What is the test that we are talking about? We are talking about the Barber's test. What are we using? We are using picric acid for this purpose. Okay, so that's the Barber's test we are basically looking at. Next question. Which of the following is true regarding the medico-legal opinion in a case of alleged rape? So a patient has come. Doctor should make the diagnosis of rape in the report. Can a doctor make the diagnosis of rape? No. Rape is not a diagnosis. It's a legal term. We cannot make the diagnosis of rape. Okay, so that is not true. A doctor should opine on whether the signs are consistent with recent vaginal penetration. That's a true statement. We can give an opinion whether or not a recent vaginal penetration has happened. We can give an opinion. Okay, that's important. Doctor must confirm or deny whether rape has occurred. Once again, there is no confirm or denial of the rape. We can only confirm and give signs, whether confirm that the signs are consistent with a vaginal penetration. Normal examination findings confirm that rape has occurred. That is not true. So the answer is going to be option number D. Next. During autopsy of a decomposed body, the post-mortem staining is noted to be dark brownish green in color, and it merges with the other putrefactive changes. Okay, Ji. Which of the following best explains the fate of post-mortem staining? So the question is on post-mortem staining, which is true about the post-mortem staining. Complete disappearance due to washing out of blood, not true. There is no complete disappearance of post-mortem staining. It gets fixed. There is lividity, right? So there is no washing out. Once the blood is washed out, the staining doesn't go away. Persistence as bluish purple discoloration until skeletonization, no. There is no one fixed color. It goes through stages of coloration, discoloration. Basically, it's not just one fixed color which is going to remain until it gets skeletonized. There is hemolysis, that is true, with diffusion of blood pigments followed by color change during the decomposition. This is the best description of postmortem staining. Fixation without further alteration, that is not true. I told you there is going to be alteration which is going to happen. Okay, so the answer is option number C. Next question. A 64-year-old man with long-standing diabetes mellitus, hypertension, and exertional angina undergoes an invasive imaging procedure after a positive treatment stress test. So what is he undergoing? He is undergoing an angiography. Okay, that is what is visible here. The accompanying sign angiographic video demonstrates selective opacification of the left coronary artery T under the fluoroscopic guidance before you move ahead with the PCI, percutaneous coronary intervention. Which of the following contrast agents is most commonly used in this procedure? So we use a non-ionic low osmolality iodinated contrast. We either use iohexol or we use ipamidol. Okay, so we are using basically iodinated non-ionic low osmolality contrast is what is preferred. Okay, all right. Next question. A 31-year-old multigravida at 34 weeks gestation reports a progressive decrease in the fetal movements over the past several days. So what is it indicating towards? That the fetal compromise is about to happen. There is a reduction in the fetal movements that is happening over a few days. She denies any abdominal trauma, vaginal bleeding, or fever. On examination, the uterine size is appropriate for gestation age. A video of the transabdominal ultrasound is provided, which are the following name signs is present. So basically, we are looking at a video where you can see that if you pause the video, you can see that there is, I can't pause it here. So there is overlapping of the skull bones that is visible. The skull bones are overlapping over each other. This is the characteristic sign in fetal demise that we talk of as the Spalding's sign. Okay, that is what is visible, that there is overlapping of the calvarium of the skull bones that can be seen. Okay, all right. Next question, what does this image most likely represent? So you can see that there is a fusiform dilatation of the CBD and the common hepatic duct as well. This is what we're talking about as the choledochal cyst. Okay, this is a straightforward, easy question. Next, a 25-year-old woman on combined OCPs for the past 6 months now presents with complaints of persistent nasal obstruction. 6 महीने से patient OCP ले रही है, अब persistent nasal obstruction के साथ आई है. Well, it has been going on. It's a persistent nasal obstruction which is not going away. There is no history of allergy, infection, or sinus disease. Which of the following best explains her condition? Allergic rhinitis, there is no history of allergy, so there is no allergic rhinitis. Vasomotor rhinitis, no, this is not true. Can it be drug-induced? Yes. So estrogen is known to cause the vasomotor regurgitation, or there is engorgement which happens. Okay, so nasal engorgement is happening, and that is what is causing a persistent feeling of nasal obstruction. This is a documented phenomena seen with estrogen, especially in females who are taking OCP. So this is a drug-induced rhinitis due to the estrogen in the contraceptive pills, and plus you have a temporal causation as well. It is happening after she has been taking OCP. Before that, it was not happening. There is no history previously. Otherwise, it could have been allergic also. Vasomotor also would have been happening before. It is specifically associated with the drug intake. So therefore, the diagnosis is going to be drug-induced rhinitis. And we know estrogen is known to cause this kind of effects with the nasal obstruction. Okay, all right. The condition shown in the video is most common cause of which type of staphyloma. So what you can see an altered, tilted kind of a disc, and what you can see, this is what is pathological myopia. So this is pathological myopia, right? So this is what is the most common finding that you get? There is thinning of the sclera, which is noted, and that is what causes posterior staphyloma. So this is what you can see here in this fundoscopic video. Okay, all right. Next question. Okay, so the image here is not very clear. We were trying to give you vesicular eruptions. So though you can see that there are crusted eruptions which are there, so there have been they have improved over time. So it shows associated recurrent episodes of redness, watering, photophobia, and foreign body sensation. So vesicular eruptions or crusted eruptions that you are seeing in the distribution of the V1 or the ophthalmic division in the trigeminal nerve, along with the involvement of the eye, where you're finding recurrent episodes of redness, watering, photophobia. What are we talking about? We're talking about the herpes zoster ophthalmicus. Okay, this is what you should be knowing. Next. A 28-year-old man presents with decreased vision following blunt ocular trauma. Observe the slit lamp video and identify the clinical sign. What you can see that there is tremulousness of the iris, tremulousness of iris that is characteristically visible. What do you see? This is basically iridodonesis because of what? There is rupture of the zonular fibers, which is causing subluxation of the lens. So the lens is subluxated. It is going to be what? The support which is there to the iris is gone. So basically with movement, there is going to be tremulousness that is going to be noticed following trauma. This is what we call as iridodonesis. Okay? All right. Next question. A patient presents with recurrent oral ulcers, genital ulcers, and hypopion uveitis. So there is oral involvement, genital involvement, and there is ocular involvement. So orogenital ocular syndrome. What is this characteristically? This is what we know is known as the Behçet syndrome. Okay. So oro-oculogenital syndrome is the Behçet syndrome. Non-granulomatous uveitis, it can involve both the anterior as well as posterior segments. Characteristically, you have hypopion which changes with position. So this is your Behçet's disease. It's a straightforward question. It has been asked multiple number of times. Next question, examine the image and identify the defect. So what you can see, you can characteristically notice these defects or pits which are seen. These are the healed trachoma follicles which are visible. What are they called as? These are the Herbert's pits that are present here. So these are the Herbert's pits that you're looking at. Where do you find the Horner Trunter spots? In vernal keratoconjunctivitis. Okay. So Herbert pits of trachoma are what is depicted here, right? Campanus is the superficial corneal vascularization that you see. This is the Horner Trunter spot. So these are the Trunter, the yellowish spots that you see at the corneolimbal margin. This is what is the characteristic Trunter spots. This is also an important spot diagnosis that you should be able to figure out. Okay, beta. So these are my share of questions. Please go back quickly. Just take a break of about half an hour. Don't give up studying, okay? Irrespective of whatever you have studied, whatever is left, the only thing that is important right now is to keep your mind stable and just keep reading whatever is left till the day of your examination. जितना हो सकता है आप पढ़ो, 14-15 घंटे पढ़ सकते हो, कोशिश करो पढ़ो, at least 12 to 13 hours you should be reading. And along with it, 1 hour, 1.5 hour question practice so that your mind remains active in that domain as well. केवल पढ़ाई theory notes मत पढ़ो, keep solving the MCQs also. And one thing you need to remember before I finally wrap it off is that it is very unpredictable, okay? Not only is the pattern changing, there are a lot of anxiety which the students have. So you don't really know whether you're in the game or out of the game. Always remember this. Everybody is stressed. Everybody is almost in the same boat. Even the toppers, maybe 500 people are maybe sure about that they are prepared well. Rest of them are still in the ambiguous zone. सारे क्वेश्चन सबको नहीं बनेंगे. 180 में से 110, 120 बनेंगे. बाकी जो ठीक होंगे लोगों के वो सिर्फ presence of mind and their ability to rule out the options because they are present in the paper. ठीक है? तो दिमाग को ठंडा रखो. जिस भी भगवान को आप मानते हो उसकी पूजा करो, भरोसा रखो कि he'll be doing the best for you. Okay? All right, beta. Thank you so much.
Hello, students. Hope you had a wonderful Sunday and a wonderful GT2. So here we are again on a Monday evening with the test discussion series, the discussion of basically the GT2 questions. I am Dr. Madhu Chaudhary and I will be discussing the pathology, microphysiology and biochemistry questions. So let's start with pathology. The first question says a 28-year-old male presents with a painless testicular mass. Serum studies reveal markedly elevated HCG, normal AFP, and elevated LDH. Histology shows a small hemorrhagic tumor composed of multinucleated syncytial trophoblast and cytotrophoblast. Which of the following is most likely the diagnosis? See, if they wouldn't have given you the histology picture, the question would have been a little difficult, but then they've given you the correct diagnosis. It is multinucleated syncytial trophoblast and cytotrophoblast. So we know the diagnosis is, yes, the answer is your choriocarcinoma. Answer is choriocarcinoma, right? Because presence of both syncytial trophoblast and cytotrophoblast, the multinucleated syncytial trophoblast and cytotrophoblast are found in necrotic tumor. And grossly, you see a hemorrhagic mass due to rapid vascular invasion. And characteristically, this tumor has elevated HCG, normal AFP, and elevated LDH. Why is HCG elevated? HCG is characteristically elevated because it is secreted from, yes, it is secreted from syncytial trophoblast, so it has to be elevated. All right. Why is it not a seminoma? Seminoma, we know a very characteristic feature, the histopathology of seminoma. What do you see? You see clear cytoplasm, central nuclei. Remember the fried egg appearance? Fried egg appearance, and you see lymphocytes in the septa, fibrous septa. And moreover, HCG, beta HCG would be normal in seminoma. Yolk sac tumor, the characteristic feature, histopathology, what do you see? You see Schiller-Duval bodies. Okay, in yolk sac tumor, Schiller-Duval bodies. Here, AFP again would be elevated, but please note that yolk sac tumor is the most common tumor seen in young boys, less than 3 years old. So unlikely, and moreover, you're not seeing Schiller-Duval bodies here. This is choriocarcinoma. Embryonal carcinoma, again, it produces both HCG and AFP. So your beta HCG and AFP would be elevated here. And plus you will see pleomorphic undifferentiated cell in the histopathology. So a correct answer here is choriocarcinoma. Simple. Let's move on to the next question. A patient presents with abdominal pain, hepatosplenomegaly, WBC count more than 50,000. Which gene is involved? So now they're not asking you what is the diagnosis. You have to arrive the diagnosis and tell the genetic defect. Very simple question. Abdominal pain, hepatosplenomegaly. Massive splenomegaly with a raised WBC count is a characteristic feature of, yes, massive splenomegaly, the patient coming with a dragging sensation in the abdomen, as if something is hanging in the abdomen, going down. The characteristic feature is of CML. And what do you see in CML? Translocation 922. What is it? Philadelphia chromosome. There is BCR ABL gene translocation. Okay, so our answer is translocation 922. Very simple. Okay, 1517 translocation, where do you see? 1517 is seen in acute promyelocytic leukemia. This is also very important. इसके बारे में भी बहुत क्वेश्चन आते हैं. APML में translocation 1517. कौन सा translocation होता है? PML RARA. Patients are more prone to DIC. और क्या मिलता है इसके अंदर? Faggot cells. What are faggot cells? You see multiple or rods. All right. APML, again, a very important question. But here our answer is CML, translocation 922. Right. Moving to the next question. Okay, a 35-year-old woman presents with painless, firm, moderate, goitrous enlargement of the thyroid. Your T3 is reduced, 60. T4 is also reduced. Radioiodine uptake is 3% at 24 hours, again reduced. Microscopic examination is given below. Which of the following is most likely? First of all, it is a case of hypothyroidism. So आपका सबसे पहले Graves disease is ruled out. Okay, and moreover Graves disease में histopathology में क्या दिखाई देता है? Scalloped colloid, which is not there. What do you see in here? What do you see? You basically see lymphoplasmacytic infiltration. You see prominent germinal centers here, plus you see normal follicles, normal thyroid follicles. And what else do you see? You see metaplastic Hürthle cells. So our correct answer here is yes, it is Hashimoto's thyroiditis. Okay, it is Hashimoto's thyroiditis. Right, I've already told you Graves disease नहीं हो सकता. Why? Because it's a case of hypothyroidism. Graves disease में hyper होता है. And moreover, scalloped colloid and elongated follicular epithelial cells are not seen here. Why is it not subacute thyroiditis? Subacute thyroiditis is not painless. It is painful, and you will get a history of viral infection. Histology में what will you see? You will see granulomatous inflammation. Okay, granulomatous inflammation होगा, plus painful होगा, history of viral infection होगा in subacute thyroiditis. Thyroid lymphoma, patients with Hashimoto's thyroiditis, long-standing cases are prone to progress to thyroid lymphoma, but presence of Hürthle cells, normal germinal centers rule out thyroid lymphoma. All right, let's move on to the next question. A 30-year-old woman presents with multiple cervical lymph nodes. Your IHC is positive for CD10, BCL2, and the smear shows numerous centrocytes and occasional large centroblast. What is the most common genetic defect? So again, they're not asking you the diagnosis. They're asking you the genetic defect. Diagnosis पहले निकालोगे तभी तो genetic defect निकलेगा. CD10 positive, BCL2 positive, multiple cervical lymph node, and centrocytes and centroblasts. So what is our diagnosis here? Yes, the diagnosis is, can anybody tell me if, okay, I should wait. Can anybody tell me what is the diagnosis? People who are watching, can anybody tell me the diagnosis? The diagnosis is follicular lymphoma. Okay, follicular lymphoma में क्या translocation होती है? It is translocation 14-18. Okay, I hope all of you remember my mnemonic for all the translocation in your B-cell lymphomas. Remember, bone marrow failure. B ka bone is your Burkitt. M is mantle. F is follicular. What do we know? Number 18 is common. ठीक है? Translocation dash 18. Your B looks like 8. So it is translocation 8-18. Mantle is TL looks like 11. So your translocation is 11-18. F is 4. 4 plus, sorry, your 14 is common here. So it is 8-14, 11-14, and 4 plus 14 is 18. So your translocation 14-18. ठीक है? Marginal को we keep it at the side. Marginal lymphoma, we keep it at the side and take the two right margins. Two right margins कौन से हुए हमारे? Right. These are the right. Two right margins. Margins हुआ 11-18. So it is translocation 11-18. All right. So our answer here in follicular lymphoma, it is 14-18. And moreover, centroblast and centrocyte CD10 positive, BCL2 positive is seen in follicular lymphoma. Right? Moving on to the next question. A 3-day-old neonate presents with a palpable flank mass. Ultrasound reveals a non-functioning multicystic structure replacing the left kidney. Now, surgical removal is planned. Histology shows cyst lined by flattened epithelium surrounded by concentric fibrous layer, along with the cartilage and primitive ducts. Which of the following additional finding is most characteristic of this condition? So we all know a 3-day-old neonate presenting with a palpable flank mass. What is the diagnosis here? It is your multicystic dysplastic kidney. Okay, multicystic dysplastic kidney, and it represents the more severe form of dysplasia in infant, more severe form of dysplasia in an infant or a neonate. So, and what is the histology of this? It is characterized by multiple cysts lined by flattened epithelium. We know here cyst lined by flattened epithelium and surrounded by concentric fibrous layer of cartilage and primitive duct, which are what? Which are basically undifferentiated mesenchyme with your smooth muscle cartilage. Okay, undifferentiated smooth muscle, undifferentiated mesenchyme and smooth muscle cartilage. So in case of multicystic kidney dysplasia, you have cyst, multiple cysts lined by flattened epithelium surrounded by concentric fibrous layer along with cartilage and primitive ducts, and these cells are along with them you find undifferentiated mesenchyme with smooth muscle and cartilage. Okay, presence of glomerular crescents. Where do you find presence of glomerular crescents? That is a hallmark of your your hallmark of your rapidly progressive glomerulonephritis. Okay. Hyperplastic juxtaglomerular apparatus, where do you see? You see it in Bartter syndrome. An extensive interstitial eosinophilic infiltrate, you see it in acute tubular necrosis, and most commonly due to drug-induced. What are the drugs we know that causes acute tubular necrosis? Basically, your NSAIDs, your penicillin, proton pump inhibitors, they are known to cause acute tubular necrosis, which has extensive interstitial eosinophilic infiltrate. So a correct answer here is B, right? Moving on to the next question. A couple seeks prenatal genetic counseling due to the family history of hemophilia. They currently have a male child with hemophilia and a normal female child. Mother has a family history. Father's no family history. What is the likelihood that the future children will be affected? Okay, it's a case of hemophilia. We all know what is the inheritance of hemophilia. It is X-linked recessive. X-linked recessive. Now, in this case, father is normal, mother has a family history. So probably mother is a carrier. Mother is a carrier. Now, what is the likelihood of the future children being affected? Before we see the options, I'll explain you with this figure. This is the unaffected father. Both the genes are normal. This is a carrier mother. One gene, one X is normal, the other X is affected. Okay. So we have X, Y, X affected, and X. Remember the Punnett square? This X will combine with this to form a carrier daughter. Okay. This X will combine with this X to form a normal daughter. Now Y with affected X, what will it be? Affected son. And this Y with normal X would be normal son. So half of their daughters would be a carrier, half of their sons would be affected. Understood? Now, let's look at the option. All the males will be affected? No, half will be affected. half of the males will be affected, half of the daughters will be carriers. This is the correct answer. Okay? All males and females will be affected? No. All males will be affected? Again, no. Because X from the one normal X from the mother will lead to half of the sons being normal. All right. I hope with this figure it will be very easy. Coming to the next question. A 58-year-old chronic smoker is diagnosed with lung adenocarcinoma. Genetic analysis shows an EML4 ALK fusion gene. Which mechanism best explains the oncogenic activity of this mutation? See, these kinds of questions, unlikely they will be asked because they will ask you what kind of genetic defect would be there rather than the consequence of this genetic activity, genetic mutation. Okay, so but here, if we see because of EML4 ALK fusion gene mutation, what happens? There is basically inversion of chromosome 2 here, the short arm. Okay, the short arm. Basically, it is P21.23. Now, this fuses the N terminal of the EML4 with the ALK gene. Okay, and this basically results in increase of tyrosine kinase activity. Okay, tyrosine kinase activity. So a correct answer here is constitutive receptor tyrosine kinase activity. Because of the fusion of EML4 and ALK gene, there is increased tyrosine kinase activity. All right. Where do you see autocrine secretion of PDF platelet-derived growth factors? Basically, you see it in astrocytomas and osteosarcomas. Impaired GTPase activity of RAS, KRAS mutation most commonly seen in your lung adenocarcinoma, but more common in smoking related. Okay, smoking related adenocarcinoma. Amplification of HER2 again in your breast cancers and some cases of gastric cancers. All right. Coming to the next question, which of the following histological finding is characteristic of ischemic acute tubular necrosis and helps it differentiate from toxic acute tubular necrosis? So they're asking about the differences between ischemic and toxic acute tubular necrosis. Before we see the options, let's quickly revise what are the characteristic differences between ischemic and toxic. Ischemic, there is patchy necrosis with skip lesion. However, in toxic, it is continuous or diffuse necrosis. The primary segments affected in ischemic is basically your straight segment of proximal convoluted tubule and the thick ascending limb. Here it is the proximal convoluted tubule only. Okay, not the straight segment, but the earlier segment P1 and P2. Basement membrane in ischemic is ruptured. What do you call? Tubular excess. However, in toxic, it is intact. And the regeneration is slower in case of ischemic. Why? Because the basement membrane is damaged. However, there is early reepithelialization in cases of toxic acute tubular necrosis. So coming to the options, what is the differentiating feature? It is the patchy tubular necrosis. Intact tubular basement membrane, no, it is seen in toxic, not in ischemic. Diffuse necrosis, again seen in toxic. Prominent subepithelial immune complex deposits, not seen in acute tubular sclerosis, it's seen in your post-streptococcal glomerulonephritis. All right? So moving on to the next question. A chronic smoker with 24-pack year smoking history presents with breathlessness, chest pain. Further investigations reveal a lung tumor with stains positive for chromogranin. Staining positive for chromogranin, what do we know? What is the answer here? It is small cell carcinoma. Okay, small cell carcinoma. And what else do you see in small cell carcinoma? You see, basically, there's a strong association with smoking, yes. And you see molding of the cell, molding of the nuclei, molding of the nuclei. And what do you see? Isoparty effect there. Okay, what is isoparty effect? The blue colored vessels that you see in small cell carcinoma. Very quickly differentiating small adenocarcinoma, most common in non-smokers. Location, we know it is peripheral. Okay, and histology, you all know it will be glandular histology. The markers, it will be positive for TTF1, positive plus it will be positive for napsin1. Then what are the mutations that you see in adenocarcinoma? You see EGFR mutation, KRAS, and the EML4ALK mutation that we just now discussed. And the most common paraneoplastic syndrome that you see in adenocarcinoma is, yes, it is migratory thrombophlebitis. Okay, these are the features of adenocarcinoma. Then squamous cell carcinoma, again, a very strong association in smokers. Location, it is central. What is the characteristic histology that you see in squamous cell carcinoma? You see keratin pearls. Okay, and the markers P63, P40 positive, plus cytokeratin 5/6 positive, and the mutation TP53 mutation is seen. And the most common paraneoplastic syndrome that you see in squamous cell carcinoma, it is hypercalcemia. Okay, it is hypercalcemia. Now, coming to small cell cancer, the answer in our question, small cell cancer, again, it is central, associated with smokers. And what do you see? I already told you, you see nuclear molding, small round cell with nuclear molding, the crushing effect, isoparty effect, the blue blood vessels. Okay, staining, chromogranin, small cell cancer, chromogranin, synaptophysin, your NSC, all will be positive. Okay, and this is the cancer where you find all kinds of paraneoplastic syndrome. What can you see? You can see syndrome of inappropriate ADH secretion. You can see Cushing's disease, and you can also see Lambert-Eaton myopathy. Okay. So this, any paraneoplastic syndrome you name, you can see it in small cell cancer. Coming to large cell cancer, location peripheral, again seen in smokers. All the markers, will be negative. The histology basically you will see pleomorphic, undifferentiated cells. Basically, this is a diagnosis of exclusion. And the characteristic paraneoplastic syndrome that you see here is gynecomastia. Okay, so very quickly, coming back to the question, chromogranin positive, chronic smoker, breathless chest pain, chromogranin positive, it is our small cell cancer only, right? Coming to the next question, a chronic alcoholic presents with progressive abdominal distension, shifting dullness is noted, liver span measures less than 7 centimeter. Your liver biopsy reveals intracytoplasmic eosinophilic inclusions within the hepatocyte. Okay, the inclusions are composed of which of the following structures? Now, before looking at the option, what is the diagnosis? Alcoholic, progressive abdominal distension, shifting dullness, liver span measures 7 centimeter, and liver biopsy, you see eosinophilic inclusion within the hepatocyte. What is the diagnosis? It is your alcoholic hepatitis. Okay, alcoholic hepatitis. And what are the eosinophilic inclusions that are called? They are called Mallory-Denk bodies. Now, what are these composed of? These are composed of, yes, they are composed of intermediate filaments. Intermediate filaments, specifically keratin 8 and 18. Okay, along with your heat shock proteins. So our answer here is intermediate filaments. Now, coming to all the inclusion bodies that you see in pathology. Mallory-Denk bodies, I already told you it's alcoholic hepatitis. Also seen in NASH, plus seen in your Wilson's disease. Lewis bodies seen in Parkinson's. Negri bodies, I hope all of you know Negri bodies is seen in your rabies. Russell bodies, where have we studied Russell bodies? We've studied in multiple myeloma. Ellie bodies, again SLE. Pappenheimer bodies, where do you see Pappenheimer bodies? You see it in sideroblastic anemia. And what are these Pappenheimer bodies? Basically, they are iron granules. So they can also be seen in iron overload. All right. They are multiple. Please note, Pappenheimer bodies are multiple iron granules, and Howell-Jolly bodies are single RNA remnant seen in your megaloblastic anemias. Megaloblastic anemias also seen post-splenectomy. These are single RNA remnant. Your Pappenheimer bodies are multiple. Or rods, everybody can tell. Your acute myeloid leukemia, multiple or rods seen in APML, acute promyelocytic leukemia, AML M3 type. Councilman bodies, viral hepatitis, and also seen in yellow fever. Samoma bodies, very favorite question of your examiner. Samoma bodies are seen in your, first of all, your papillary thyroid cancer, meningiomas, serous ovarian adenocarcinomas. Dutcher bodies, again, multiple myelomas. Cowdery type A bodies, seen in your herpes simplex virus infection. Owl's eye inclusion. We are not saying owl's eye appearance. Owl's eye appearance आपका Reed Sternberg cell आएगा. Owl's eye inclusion is seen in CMV. And please note your Dutcher bodies, Cowdery type A, owl's eye inclusion are all intranuclear. ठीक है, बाकी सारे साइटोप्लाज्मिक इंक्लूजन्स हैं, ये तीनों इंट्रान्यूक्लियर है, राइट? सो Mallory Denk bodies are made up of intermediate filaments. That is a correct answer here. Coming to the next question. Okay, a 42-year-old man presents with fatigue, splenomegaly, leukocytosis, bone marrow. There is hypercellularity. Cytogenetic analysis reveal a 922 translocation. Which oncogene is implicated? I just now explained in a previous question. Fatigue, splenomegaly, leukocytosis. So your answer is CML. Bone marrow is also hypercellular. Answer is CML. We've already know it is translocation 922, BCR, ABL, fusion, sorry, BCR, ABL translocation, and it is Philadelphia chromosome. ठीक है, तो oncogene implicated यहाँ पे कौन सा होगा? Very obviously, it is ABL. All right, so this is the correct answer. Red gene mutation कहाँ पे देखते हैं हम? Mostly seen in your MEN syndrome, MEN2A, MEN2B, papillary thyroid cancer also. ALK, we just now studied EML4, ALK fusion, lung adenocarcinoma. JAK2, again in myeloproliferative neoplasm, but wherever Philadelphia chromosome is negative. और वो कहाँ पे होता है? Polycythemia vera. All right, so coming to the next question. A 65-year-old woman is found to have multiple yellow nodular submucosal masses in the terminal ileum. So it is terminal ileum, multiple yellow nodular submucosal masses. Biopsy reveals nests of small round cell with granular cytoplasm, then stained positively with silver salt. Which of the following statement is most accurate regarding her condition? So first of all, what is the diagnosis? The diagnosis is carcinoid tumor. Okay, carcinoid tumor, and we know carcinoid tumor is known to occur in terminal ileum. Multiple yellow nodular masses होते हैं और उसकी biopsy में भी histology में you will get small round cell with granular cytoplasm. Now, they stain positive for silver salt. Why? Because these cells secrete serotonin. Serotonin 5-HT, and these are stain positive for silver salt. Okay, that is why they stain positively with silver salt. So, what is the correct answer here? The tumor is mostly likely of hindgut origin. No, carcinoid कहाँ से originate करता है? Midgut से. It originates from the midgut. So this is wrong. The tumor is typically solitary. No, it is multiple. The tumor is neuroendocrine tumor, argentefine or silver positive. Yes, this is the correct answer. Okay. It rarely metastasizes. No, it metastasizes. All right. So this is also incorrect. C is the correct option. Moving on to the next question. An elderly patient presents with anemia and hemoglobinuria. Investigation shows elevated LDH. Based on the peripheral smear of the image provided, which of the following physical examination finding would likely support the diagnosis? Okay, first of all, we'll have to find out what is the diagnosis. Anemia hai, hemoglobinuria hai, elevated LDH hai. So is it a case of extravascular or intravascular hemolysis? Hemoglobinuria hai, elevated LDH hai, so it is a case of intravascular hemolysis. Now, coming to the smear, what do you see in smear? What do you see in smear? What kind of cells are these? These are helmet cells. And these are schistocytes. Okay, schistocytes are fragmented cell helmet cells. So where do you see these kind of cell? Microangiopathic hemolytic anemia. Microangiopathic hemolytic anemia, इन ऑप्शंस में से कुछ पॉसिबल है? स्प्लीनोमेगैली? नो, स्प्लीनोमेगैली कब होती है? जब हमारी एक्स्ट्रावास्कुलर हीमोलिसिस होती है. ठीक है. फ्रंटल बॉसिंग हमारा कहाँ पे होता है? थैलेसीमिया में, जहां पे एक्स्ट्रा मेड्युलरी हेमाटोपोइसिस होगा, और एल्डरली पेशेंट में ये पॉसिबल नहीं होगा. यंग पेशेंट में होगा थैलेसीमिया, फ्रंटल बॉसिंग होगी, एक्स्ट्रा मेड्युलरी हेमाटोपोइसिस होगा. Goiter, again, no relation with hemolytic anemia. Mechanical second heart sound. Yes, this would be the supporting physical finding. Why? Mechanical heart sound कब आएगा? Because the secondary to a prosthetic cardiac valve. Secondary to a prosthetic valve, जहाँ पे turbulent blood flow होगा. Because of that, there is intravascular hemolysis, and because of that, there is a mechanical second heart sound. Okay, so this is the correct answer. Moving to the next question. A 2-day-old infant with poor feeding and bilious vomiting is diagnosed with congenital megacolon and aganglionic segment of the colon as shown in the image. Now, which layers are affected in this condition? सबसे पहले 2-day-old, poor feeding, bilious vomiting. Okay, congenital megacolon. That means there is an obstruction, there is a congenital megacolon, and we already know there is aganglionic segment of the colon. So, ganglions are absent. Now, let us label the segments. Let us label the layers of the colon. What is this? This is your mucosa. This is your submucosa. This is your mesenteric or muscular layer. This is your adventitia. Okay. So A ganglion कहाँ पे absent होंगे? A ganglion present कहाँ पे होते हैं? Remember हमने क्या पढ़ा हुआ है? Anybody? MASM. Okay. Mesenteric में और muscular में we have Orbox plexus. Submucosa में we have mucinous plexus. Okay, सबम्यूकोसा में mucinous plexus, myenteric में orbox plexus. तो ये एक ganglion कहाँ पे होंगे? Submucosa and myenteric. That is 2 and 3. Our answer is layer 2 and 3. Okay, now what is the diagnosis? Diagnosis we all know it's Hirschsprung's disease. Hirschsprung's disease के features हम कैसे याद करते हैं? Just remember sprung, struck. अब sprung we know submucosal layer होता है, उसके अंदर myenteric mucinous plexus absent होगा, proximal colon dilatation, R के अंदर you need to do a rectal biopsy, U के अंदर unable to pass meconium, NG we will take together, no ganglion. Struck को आप RET mutation कर दीजिए. Okay, simple. Submucosal involved, proximal submucosal and muscular involved, proximal dilatation, rectal biopsy is needed, unable to pass meconium, no ganglion associated with RET mutation. All right. Okay. Next, moving on to the next question. A 35-year-old man presents with a non-healing wound over the shin for the past 4 weeks. Examination reveals a raised red moist tissue over the wound surface that bleeds easily on touch and prevents the wound edges from approximating. What is the most likely diagnosis? So it's a raised red moist wound surface that bleeds easily, and there is basically the edges have not been able to join together. Because of this, the edges have not been able to join together. So what is the most likely diagnosis? Is it hypertrophied scar? No, because hypertrophied scar will not develop only after 4 weeks. It will develop months after months. And it will not be an active friable mass. Okay, like this. So keloid also, it is an overgrown scar tissue. It is not, it's not a friable tissue that bleeds easily on touch. The answer is exuberant granulation tissue. Okay, exuberant granulation tissue which bleeds on touching and it is preventing the wound edges from joining together. Wound dehiscence, again, wound dehiscence, you would have been given a history of a previously closed wound. Here this is saying non-healing wound. So non-heal, अभी तक एक बार भी heal नहीं किया. Okay, wound dehiscence होता है previously closed wound that opens up or gapes up. Right? Coming to the next question, a 45-year-old man with hearing loss, gait disturbances, presents with a cerebellopontine angle mass. Histopathology shows antennae A, antennae B, Verroque bodies. Do I need to tell the answer? Antennae A, antennae B, Verroque bodies. Our answer is yes, schwannoma. All right. I very summarized the hallmark features of all the CNS tumors that are most likely to be asked in your exam. Rosenthal fibers, you see in pilocytic astrocytoma, pseudo-palisading necrosis. Pseudo-palisading, remember pseudo-palisading, glioblastoma. Fried egg appearance, oligodendroglioma, perivascular pseudo-rosettes. Remember perivascular and pseudo-rosettes, ependymoma, homerite rosettes, it's your medulloblastoma, psammoma bodies and whorls, we all know it is meningioma. Verroque bodies, our answer here is schwannoma. Machine oil fluid seen in craniopharyngioma, right? Please try to remember all these features. Kisi na kisi form mein they can be asked, right? Moving on to the next question. Coming to the physiology questions now, select the correct option regarding the rapid ejection phase. Okay, rapid ejection phase. Rapid ejection phase, what do you mean? that the ventricular pressure is basically driving the rapid ejection by staying higher than the aortic pressure. All right. Ventricular pressure remains higher than the aortic pressure, or your aortic ventricular pressure remains higher than the aortic pressure. Am I saying it right or wrong? Can anybody tell me? Yes, ventricular pressure हाई होगा तभी तो वो आयोटा में जाएगा ना. वेंट्रिकुलर प्रेशर हाई होगा तो वो आयोटा में जाएगा. वेंट्रिकुलर प्रेशर हाई है, आयोटिक प्रेशर लो है. So that is our answer here. Aortic pressure is below the ventricular pressure. That is why it will go rapidly ejection hoga. Right? Okay. Coming to the next question. In this graph depicting partial pressure of oxygen, carbon dioxide, and ventricular and ventilation perfusion ratio of the right lung, what point corresponds to the condition where the alveolar blood flow is completely blocked in case of a pulmonary embolism? Now, in case of a pulmonary embolism, क्या होगा? हमारे पास ventilation perfusion ratio है. In case of a pulmonary embolism, क्या होगा? Your ventilation would be intact and perfusion would be 0. Okay, ventilation intact रहेगा, perfusion in 0 रहेगा. So इसका क्या मतलब हुआ? This is the physiology of your. This is the physiology. Yes, can anybody tell me? This is the physiology of your dead space. Okay, this is dead space, where your perfusion is 0 but ventilation is intact. So हमारा ventilation और perfusion ratio क्या होगा? जब ये 0 हो जाएगा तो this ratio would be infinity. और ये हमारा point कौन सा होगा? The farthest point. Okay, this is the farthest point. When ventilation is 0 and perfusion is intact, तो V by Q हमारा हो जाएगा 0 and this would be your 0.1. नॉर्मल होगा हमारा यहाँ पे where the ventilation perfusion ratio is almost equal to 0.8. ठीक है. सो यहाँ पे आंसर डेड स्पेस की फिजियोलॉजी में होगा हमारा 0.4 और पॉइंट डी. आंसर डी. राइट. नाउ कमिंग टू द नेक्स्ट क्वेश्चन. They've given you a big table of the thyroid function test in 4 different patients. Patient 1, 2, 3, 4. A physician is reviewing these 4 patients' thyroid function test. Which of the following most accurately identifies all the 4 patients and explains the physiologic basis for the TRH response test in each? Okay. Now let's analyze. They've given the options in the next slide, but let's analyze each and every patient here. Patient 1. Patient 1 में क्या है? T3 high है, T4 high है, TSH low है, and thyroid bonding globulins absent, normal, ठीक है. TRH test responses abnormal. So that means it's a case of primary hyperthyroidism. ठीक है. प्राइमरी हाइपरथायरॉयडिज्म है बिकॉज टीआरएच टेस्ट फ्लैट है या नॉर्मल अबनॉर्मल है. योर टीएसएच इज लो, T3 T4 इज हाई. प्राइमरी हाइपरथायरॉयडिज्म का एग्जांपल ग्रेव्स डिजीज, टॉक्सिक नोड्यूल, राइट. मोरओवर यहाँ पे बीएमआर भी हाई है. सो इट हैज टू बी केसेस ऑफ प्राइमरी हाइपरथायरॉयडिज्म. कमिंग टू पेशेंट 2. पेशेंट 2, योर T3 T4 आर लो, TSH हाई हो जाएगा, नो एंटीबॉडी, थायराइड बाइंडिंग ग्लोबुलिन नॉर्मल है, T3 T4 भी लो है, TRH response is exaggerated. So this is a case of primary hypothyroidism. Okay, this is a case of primary hypothyroidism. Where do you see? Hashimoto's thyroiditis. ठीक है. Because there is a lack of negative feedback from the low thyroid hormones, so हमारा TSH raised है, there is exaggerated response, TRH, तो primary hypothyroidism है. Now coming to patient 3. Patient 3, ये तीनों लो हैं. Okay, T3 भी लो है, T4 भी लो है, TSH भी लो है. So it is a case of hypothyroidism. What hypothyroidism? Secondary hypothyroidism. Okay, secondary hypothyroidism. Even if the pituitary is not able to secrete the TSH. Let's see the TRH response test. Pituitary जब नहीं है तो TRH flat response दे रहा है. Okay, coming to patient 4. Patient 4 आपका T3 T4 high है, TSH भी high है. So again it is a case of secondary hyperthyroidism. Okay, so we have primary hyper, primary hypo, secondary hypo, and secondary hyper. Right? Now let's see the options here. यहाँ पे हमारा क्या option होगा? Primary hypo था, let's see primary hyper, primary hypo. So we have primary hyper, primary hypo, secondary hypo, secondary hyper. Let's see the options here. Primary hypo, no. Primary hyper, primary hypo, secondary hypo, secondary hyper. All right. So this is a correct option. You just have to see आपके TSH level का क्या relation है in relation to your T3, T4 level and your TRH response coming from the hypothalamus. All right. So this is the correct answer. Moving on to the next question. A 28-year-old primary gravida in active labor is administered oxytocin to enhance the uterine contraction. Which of the following second messenger system is most likely activated by oxytocin? So you have a primary gravida, active labor, oxytocin दिया है, enhance uterine contraction, second messenger system कौन सा activate होता है? We know oxytocin acts via the G protein couple receptors. Okay, G protein couple receptors, and what do? They basically stimulate the phospholipase C. They stimulate phospholipase C. They stimulate phospholipase C to cause contraction. So हमारा यहाँ पे आंसर हुआ phospholipase C. All right. Coming to the next question. The clearance of a subject X, Y, and Z are studied on different concentrations in blood. Match the correct answer to the following. So they've given you they've given you the renal clearance of various substances. Renal clearance refers to the volume of a plasma that is completely cleared of a substance by the kidney per unit of time. Okay, and these curves tell us basically the concentration, how the plasma concentration indicates the clearance of a substance, the renal clearance of a substance. If you see substance X क्या है? It is horizontal. It is horizontal and it is basically neither increasing nor decreasing. That means it is equivalent to your GFR, the glomerular filtration rate. So it is neither reabsorbed nor secreted. ठीक है, neither reabsorbed nor secreted. और इन तीनों में से ये substance कौन सा है? Inulin. Okay, it is being neither reabsorbed or being secreted. Now, substance Y क्या है? At low plasma concentration, जब इसका plasma level low होता है, तो उसका clearance high होता है. ठीक है, लो प्लाज्मा लेवल पे उसका क्लियरेंस हाई होता है. दैट मीन्स इट इज बीइंग फिल्टर्ड, एट द सेम टाइम इट इज बीइंग सिक्रीटेड इनटू द ट्यूब्यूल्स आल्सो. ठीक है, इट इज बीइंग सिक्रीटेड आल्सो. बट जब प्लाज्मा लेवल बढ़ता है, व्हेन द प्लाज्मा लेवल इज इंक्रीजिंग, हियर कर्व वाई में जब द प्लाज्मा लेवल इज इंक्रीजिंग, उसका सिक्रीशन कम होता जा रहा है. Why? Because the secretors are getting saturated. So that substance is your basically para-amino hippuric acid. your PAH. This is your PAH. Okay. Now, coming to Z, normal plasma level पे, there is no clearance. This is the normal plasma level. There is no clearance. इसका क्या मतलब होता है? जितना फिल्टर हो रहा है, उतना ही रीअब्सॉर्ब हो रहा है. ठीक है. But as the plasma level increases, उसके रीअब्सॉर्प्शन रिसेप्टर्स, उसके क्या होता है? The renal threshold is increasing, so it is further cannot be reabsorbed, and hence it is being filtering out in the kidney. And this is your glucose. Because जब normal plasma level होता है तो entire amount is reabsorbed. There is no filtration. But as the concentration increases, उसका reabsorption कम होता जाता है. ठीक है? Okay. So हमारे यहाँ पे options हैं. X is your inulin, Y is PAH, and Z is glucose. All right. Coming to the next question. Okay. I have summarized this. Inulin का filtration ही होता है. It is constant. The clearance curve will be constant. That is flat होगा, equal to GFR, straight line होगी. pH में क्या होता है? Filtration हो रहा है और secretion भी हो रहा है. Initially high है, but as the plasma level increases, its secretion is reached to maximum. उसके बाद वो decrease करना शुरू करता है. ग्लूकोज में क्या होता है? फिल्ट्रेशन हो रहा है, रीअब्सॉर्प्शन हो रहा है. इनिशियली उसका कोई क्लियरेंस नहीं है, बट जब उसका मैक्सिमम सैचुरेशन रीच्ड होता है तो इट इज स्टार्ट फिल्टरिंग इन द किडनी. ओके. नाउ इफ द क्लियरेंस रेशियो इज मोर देन 1, सब्सटेंस सेक्रीट होता है. इफ इट इज लेस देन 1, it is reabsorbed like glucose or urea. Okay. Coming to the next question. Which of the following transporter is responsible for co-transport of glucose and sodium across the brush border membrane of the intestinal epithelium cell? So glucose and sodium on the brush border. दोनों क्या हुआ? As the name suggests, sodium glucose co-transporter 1 located on your brush border or the apical membrane of the enterocyte. ये क्या करता है? It basically actively transports 2 sodium ion alongside 2 sodium ions with 1 molecule of glucose. All right. So this is the correct answer. जो हमारा GLUT2 transporter होता है, that is present on the basolateral. Okay, and it basically allows passive transport of your glucose, galactose also, and fructose, but it is passive transport only. Sodium potassium ATPase कहाँ पे होता है? Again on the basolateral surface. इसमें 2 sodium in होते हैं, 3 sodium in होते हैं and 2 potassium out होते हैं. CFTR, basically these are chloride channels again located on the apical cell, do not transport glucose. So हमारा आंसर है sodium glucose co-transporter on the brush border membrane. Okay, coming to the micro question. Very simple, straightforward question. Coronavirus replication is most similar to which of the following virus families? We already know it is Togaviridae families. ठीक है. Basically both are enveloped positive sense single-stranded RNA viruses. Okay, single-stranded RNA viruses. Coming to the next question. A 20-year-old college student presents with fever, sore throat, cervical lymphadenopathy, fatigue for 1 week. Peripheral smear shows atypical lymphocytes. The physician orders Paul Bernal test, which detects the heterophile antibodies using sheep red blood cells. We all know that. Which infection? सबसे पहले college student है, atypical lymphocytes है, and Paul Bernal test positive है. तो हमारा आंसर होगा very simple, straightforward. क्या आंसर होगा? Your Epstein-Barr virus infection, EBV infection. ठीक है. And what are these atypical lymphocytes called? These are called your Downy cells, and these are basically activated CD8 plus T cytotoxic cells. Okay. Also called, this disease is also called infectious mononucleosis or Kissing's disease. Right? Looking at the other option, CMV infection में क्या होगा? CMV infection में सबसे पहले pulmonal test negative होगा. Okay, and atypical lymphocytes हो सकते हैं, but pulmonal test negative होगा. Streptococcus pyogenes के लिए भी pulmonal test negative होगा, and you will not see atypical lymphocytes there. Mycoplasma infection के लिए you will see immunoglobulins. What you will see? Cold agglutinins. ठीक है? So a correct answer here is Epstein virus bar infection. Now coming to the next question, a 30-year-old gardener visited hospital with complaint of painless nodulo-ulcerative lesion on the forearm, which has progressively spread along the lymphatic channels. It has progressively spread along the lymphatic channels. He recalls a history of thorn pick while working. Thorn pick while working. ठीक है, गार्डनर है, थॉर्न पिक हुआ. हिस्टोपैथोलॉजी रिवील्स cigar shaped yeast cells surrounded by eosinophilic radiating extensions. Which of the following is the drug of choice? Again, they've asked you the drug of choice. They have not asked you the question. They have not asked you the diagnosis. Diagnosis क्या होता है हमारा? गार्डनर है और थॉर्न पिक है, तो हमारा डायग्नोसिस हुआ स्पोरोट्राइकोसिस. Okay, and cigar shaped yeast cells हैं, and you have eosinophilic radiating extension. What are the eosinophilic radiating extensions called? Splendor Hoppele phenomena. Okay, Splendor Hoppele phenomena. Basically, these are antigen antibody complexes that surround the organism. So, इसके अंदर हमारा drug of choice क्या होगा? Drug of choice is itraconazole. All right. Coming to the next question. A patient presents with fever, chronic cough. Sputum is negative, but chest X-ray indicates possible tuberculosis. So what is the next step? As per the recent National Tuberculosis Eradication Program, the guidelines, what is the next step in case of sputum negative, but chest X-ray positive? It is, yes, it is CBNA-AAT. What do you mean by CBNA-AAT? Cartridge-based nucleic acid amplification test. So this is the next step of investigation. If you see this diagnostic as per the new TEP guidelines, patients who are smear negative and chest X-ray suggestive, people living with HIV, or clinically high suspicion. Again, smear negative, chest X-ray is also not possible or not available. Clinically high suspicion, you do a CB-NAT, right? So this is the correct answer here. Coming to the next question, a 45-year-old man presents to the emergency department with complaints of severe throat pain, low-grade fever, development of thick grayish membrane over his tonsils. Okay, thick grayish membrane over his tonsils. They've already told you he's diagnosed with diphtheria. Causative organism produce an exotoxin that inhibit host cell protein synthesis by ADP ribophosphorylation or elongation factor 2. Which of the following bacterial exotoxin also function by ADP ribosylating host protein? So we already know एक तो bacterium कौन सा है? Corynebacterium diphtheriae, because it's a case of diphtheria. ठीक है? As it is also we know कि ADP phosphorylation, ribosylation होता है of the elongation factor 2. And the other organism, yes, it is E. coli. Okay? So this is the correct answer. Coming to the next question. A patient with desert rheumatism has lab findings showing a thermally dimorphic fungus that forms arthroconadia. which is the causative fungus. So we know it is desert rheumatism or dimorphic fungus. सबसे पहले, what are the characteristic features of desert rheumatism? The clinical triad of desert rheumatism, it is basically fever, erythema multiforme, and arthralgia, also known as valley fever. Okay, this is also known as valley fever. और हमारा diagnosis क्या है यहाँ पे? What is the causative agent? It is Cocoides immitis. It's a dimorphic fungus. Soil or या environment में what does it form? It forms hyphae. ठीक है, fragmented hyphae that form the barrel-shaped arthroconadia. And in the tissues, this is in the soil or environment. In the tissues, it forms spherules. Okay, it forms spherules. All right, so the correct answer here is Cocoides immitis. Coming to the next question, a 53-year-old female with HIV and AIDS has developed profuse diarrhea since the last 2 weeks. Stool wet mount examination did not show any parasite. Stool culture also, there is no pathogen. CD count is reduced. In Kin-Yon staining of the stool specimen, rounded structures measuring 4 to 6 micron are seen. Which of the four most likely is the causative pathogen? Now, in this case, you see bright pink organism in Kin-Yon staining or modified acid fast staining. And the organism here is your Cryptosporidium parvum. Okay. Cryptosporidium parvum producing spherical round oocytes and appearing acid fast on positive or bright pink positive on Kin-Yon staining, right? So this is the correct answer. Moving to the next question. Which of the following parasites produces microfilariae that are sheathed and lack nuclei? So sheath bhi hai and lack nuclei at the tip of the tail. So the answer here is Vaucheria bancrofti. All of the other have nuclei up to the tip. Brugai malaya and Brugai timori, they basically have nuclei at the tip. 2 nuclei at the tip, they are sheathed, but Manzanella is unsheathed. Okay, so bearing nuclei at the tip is bancrofti. Remember, bearing nuclei, bancrofti, BB. Okay, so I have analyzed all these sheathed organisms with tail tip nuclei. Vaucheria bancrofti, it is sheath, but the tail tip nuclei is absent. Brugia malaya, again sheath, 2 distinct terminal nuclei. Loa is unsheathed, but continuous nuclei are present to the tip. Onchocercura volvulus, again, both are absent. Manzanella, unsheathed hai, but the nuclei extends up to the extreme to the tip. All right, so our answer here is Vaucheria bancrofti, where the tail tip nuclei are absent. Coming to the next question, which of the following statement is false regarding rapid diagnostic test for malaria? Rapid diagnostic test for malaria, HRP2 is specific for Plasmodium falciparum. Yes, it is correct. Based on the principle of immunochromatography, again, we know, cannot differentiate between non-falciparum malarial species. Again, right. Aldolase is specific to Plasmodium vivax? No. This is a false statement. Aldolase is specific to Plasmodium vivax? No. Rapid detection test is basically for all the Plasmodium species, not only for Plasmodium vivax. Okay? So this is the false statement. Moving to the next question, methods of sterilization with the medium used. हॉट एयर ओवन किसके लिए होता है? टेस्ट ट्यूब्स के लिए. इंसिपिसेशन, we know it is LG medium. Autoclave, culture medium. Flame, inoculating wire. So हमारा 1 है C, 2 is A, 3 is D, and 4 is B. So the correct answer is 1C. This is the correct answer. All right. Moving on to the next question. Coming to the biochemistry questions now. The ATM gene involved in ataxia telangiectasia is located on which chromosome? This is a one-liner previously asked. It is located on your 11 chromosome, 11q22 23. All right. Now, what does ATM gene do? It basically acts as a master regulator of your DNA damage response, particularly checking or controlling the cell cycle at your G1S, S, and G2M. Okay. It is basically just controlling the cell cycle at these positions, and the mutation already we have been told it is involved in ataxia telangiectasia, right? Located on chromosome 11. Moving to the next question. A 7-day-old neonate presents with poor feeding, vomiting, lethargy, recurrent seizures. Urine is noted to have a characteristic sweet odor similar to burnt sugar. Laboratory studies reveal marked ketoacidosis. Rothera's tests remain positive even after boiling and cooling of the urine. Which of the following enzyme deficiency is most likely responsible? So, vomiting, lethargy, recurrent seizures, sweet odor, burnt sugar. The diagnosis is maple syrup urine disease. Okay, and इसमें कौन सी enzyme deficient होती है? We already know enzyme deficient is branched alpha keto acid dehydrogenase complex deficiency होती है. And what does this branch alpha chain alpha keto acid dehydrogenase do? It basically dehydrogenases your complex, degrades your branch chain amino acid. Which branch chain amino acid? Your leucine, isoleucine, valine. So there is accumulation of your alpha keto acids, and which lead to your sweet, odory, burnt sugar smell. And your Rothera's test is also positive. There is marked ketoacidosis. So it is branch chain alpha keto acid dehydrogenase complex deficiency. Phenylalanine hydroxylase deficiency कहाँ पे होती है? It is basically your phenylketonuria. And phenylketonuria में the patient will present with intellectual disability. And उसमें characteristic urine odor क्या होता है? Musty odor. Okay, musty or mousy odor. Then homogentisic oxidase deficiency किसमें होती है? Alkaptonuria. And the patient will present with urine that turns black on standing. Patient will present with ochronosis, arthritis. Cystathione beta synthase deficiency होती है homocystinuria में. ओके, पेशेंट का लेंस सबलक्सेशन होगा, मार्फेनॉइड फीचर होंगे, एंड लेंस सबलक्सेशन होगा. सो आर आंसर इज branch chain alpha keto acid dehydrogenase complex deficiency, maple syrup urine disease, right? Coming to the next question, a community in a rural area has been relying heavily on a particular legume as staple food because of poor crop availability. Over several months, multiple individuals develop progressive stiffness and weakness of both the lower limb, difficulty in walking, require a stick for support. Your video shows the plant being cultivated in the community. Identify the plant and determine which vitamin may help in reducing the associated toxicity. So, कौन सा प्लांट है? सबसे कैरेक्टरिस्टिक इसके क्या है? द ब्लू फ्लावर्स कैरेक्टरिस्टिक इज योर केसरी दाल. ओके, केसरी दाल. और योर लाथेरिस्मस sativus. sorry, it is Lathyrus sativus, kesari dal, usually in cases of drought, in cases of famines, this crop is eaten by the poor villagers and they develop lathyrsis, न्यूरोलैथरिज्म. जो सारे फीचर्स दिए गए हैं वो किसके हैं? न्यूरोलैथरिज्म के. ओके, न्यूरो लैथरिज्म के सारे फीचर्स दिए गए हैं. ठीक है. एंड नाउ दे आस्क यू विच विटामिन helps in reducing the associated cytotoxicity. We know it is vitamin C. Okay. Moving on to the next question. A patient presents with hepatomegaly, recurrent fasting hypoglycemia. Laboratory analysis reveals accumulation of limit dextrin. So we know it is a glycogen storage disorder. Limit dextrins होते हैं, hypoglycemia है, hepatomegaly है. And limit dextrins are accumulated. Which enzyme deficiency है? What is the disorder? It is type 3 glycogen storage disorder, also known as Cory's disease or Forbes disease. So हमारी enzyme deficient कौन सी है यहाँ पे? D-branching enzyme. Okay. Very quickly, type 1, type 0, no name, glycogen synthase is deficient. Type 1, von Gierke disease, glucose 6 phosphatase. Type 2 is Pompe's disease, alpha 1 4 glucosidase. Type 3 जो हमारा आंसर है, D-branching enzyme is deficient. Type 4 is your Anderson's disease, branching enzyme. Type 5 McArdle, muscle phosphorylase is deficient. Type 6 is HERS, बस उसमें liver phosphorylase होता है. Type 7 is your Taraud's disease, phosphofructokinase 1. Okay. Coming to the next. Okay. Various glycogen storage disorders and आपके पास clinical presentations आते हैं. Hepatomegaly type 1 to 6 में आपके hepatomegaly होती हैं. Type 0 के अंदर there is no hepatomegaly. बाकी सबके अंदर hepatomegaly होती है. Limit dextrin type 3 में accumulate होते हैं. Hypoglycemia 1, 3 and 6. Muscle cramps and weakness 5 and 7. ठीक है. You can try and remember these pointers that can help you in identifying the various glycogen storage disorders. Coming to the next question. A man remains trapped without food for 5 days but survives. During this prolonged fasting state, which metabolic process primarily supplies energy to his brain? So it is more than 5 days. What is the metabolic process that is supplying energy to his brain? First 24 hours में क्या होगा? 0 to 24 hours में what is the process responsible for supplying energy? It is your glycogenolysis. Okay, basically the glycogen from the liver gets depleted. It is responsible for your energy glucose supply. 1 to 3 days में क्या होगा? It will be your gluconeogenesis. Okay, all the other substances like lactate, glycerol, all the other amino acids will be useful for glucose production. After 3 days and specifically after 5 days, it will be your ketosis. Okay, ketosis. That is, in cases of prolonged starvation, the liver will shift to ketogenesis. And ketosis, ketone bodies basically will be responsible for crossing the blood-brain barrier and for supplying energy to the brain. See, lipolysis में क्या होता है? Lipolysis में fatty acids secrete होते हैं. Free fatty acid release होगा livers, adipose tissue से. Not in the liver, but in cases of in adipose tissue, lipolysis, there would be free fatty acids would be released. But these free fatty acids themselves, they cannot cross the blood-brain barrier. Blood-brain barrier आपका ketosis से ही होगा. ठीक है? In cases of prolonged starvation, ketosis is responsible for supplying energy to the brain. Coming to the next question. given the following enzyme kinetic parameters. You've given the maximum velocity Vmax, you've given the Michaelis constant, your Km initial velocity is also given. What is the substrate concentration of the given enzyme? Need to just apply simple maths. हमारा equation क्या होता है? Initial velocity is equal to your Vmax into your substance upon Km plus the substance. ठीक है, ऊपर multiplication है, नीचे addition है. Now just solve this equation. VO क्या हमारा 60, Vmax 120 into substance upon 30 plus substance. ठीक है, इसको पूरा हम यहाँ ले जाएंगे. 60 into 30 plus S is equal to 120S. So 1800 plus 60S is equal to 120S. 1800 is equal to, ये यहाँ चला जाएगा, 120 minus 60, 60S. So हमारा 1800 is equal to 60S. S would be equal to 1800 upon 60. That is 30. Okay. So this is a correct answer. Simple maths है. You just need to know the equation. ठीक है? Moving on to the next question. A young patient with uncontrolled type 1 diabetes presents with fruity breath odor, deep rapid breathing. Laboratory tests confirm significant ketosis. Which of the following metabolic changes primarily contribute to the development of ketosis in type 1 diabetes? So this is a case of diabetic ketoacidosis. They've already told you what are the following processes that occur in diabetic ketoacidosis. Decreased beta oxidation of fatty acid? No, there is no decreased beta oxidation. Increased, it is increased beta oxidation. Increased release of free fatty acid from the adipose tissue? Yes. Reduced entry of acetyl coenzyme into your TCA cycle? Again, yes. Increased activity of beta hydroxybutyrate dehydrogenase? Again, this is true. So, हमारा correct answer is B, C, and D. These are the correct answers. Okay. So with this, we come to the end of the session. I hope I've been able to sort your queries and concerns. In case you have any further queries, in case you have any confusion with any question, please do write back to us. For the time being, keep on solving MCQs, keep on giving GTs, keep on revising your weak topics, and keep on solving MCQs as many as possible. Thank you. Good night. Hope you had a wonderful session. Thank you.